The following podcast is part of a certified educational activity titled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy. Focus on moderate to severe atopic dermatitis, Prurigo nodularis, chronic urticaria, and Bullous Pemphigoid. Access the entire activity and complete the post-test at peerview.com/SVX860. Downloadable slides and practice aids are also available. Welcome to this educational activity titled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy. Focus on moderate to severe atopic dermatitis, Prurigo nodularis, chronic urticaria, and Bullous Pemphigoid, featuring expert discussions from Dr. Peter Leo, Dr. Sean Quatra, Dr. Adam Friedman, and Professor Dede Morel. The faculty's goals for this activity are to equip you with strategies to differentially diagnose and assess disease severity in patients with atopic dermatitis, Prurigo nodularis, chronic urticaria, and Bullous Pemphigoid, to teach you the mechanisms of action of targeted biologic therapies in addressing the pathophysiology of chronic dermatologic diseases characterized by type 2 inflammation, and to help you identify appropriate patients for biologic therapy according to recent clinical evidence supporting their use, and develop individualized treatment plans considering factors such as disease severity, treatment history, comorbidities, and patient preferences.
Hello, this is Dr. Peter Leo from Northwestern University Feinberg School of Medicine and the Chicago Integrative Eczema Center in Chicago, Illinois. Welcome to this educational activity on atopic dermatitis. This activity is part of a 4-part curriculum titled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy. Focus on moderate to severe atopic dermatitis, Prurigo nodularis, chronic urticaria, and Bullous pemphigoid. You can access the full curriculum at peerview.com. So let's begin with an understanding that some 9.6 million children and 16.5 million adults in the United States have atopic dermatitis. Now, somewhere on the order of 1/3 of these patients have moderate to severe disease. For adults, we know that about 7% have atopic dermatitis, and many of them actually began after 2 years of age, with 40% affected by moderate to severe disease. The disease course of atopic dermatitis, it is chronic, but it's intermittent. When it's active, there can be intense itch and the rash can be truly debilitating. The burden of the symptoms can be profound. It affects the quality of life, particularly in those more moderate and severe cases, and we know there are many comorbidities like depression, anxiety, and sleep disturbance. For these patients in particular, systemic therapies are commonly used and often are really required because we can exhaust our topical armamentarium very quickly. We know that the distribution of the disease does vary by age. Babies up until maybe around 2 years of age often have face involvement, especially those cheeks. Many times the scalp, the ears, and the extensor pattern is often seen. For toddlers and throughout childhood up to puberty, we still see face involvement, but we tend to have more flexural involvement, the classical distribution of atopic dermatitis that you might see in a textbook. And then as we head towards teenage years and adult years, we see again more flexural, but also more acral, hands, feet, and sometimes again face and neck get involved. The diagnosis of atopic dermatitis is generally very straightforward. There are just 3 key features that are essential to making the diagnosis. The first is that it has to be eczematous, both in morphology and the pattern, which is sometimes age-specific. The second is it absolutely has to be itchy. And the third, it has to have a chronic or relapsing history. That's really all you need. There are a number of important features that can support the diagnosis: an early age of onset, having personal or family history of allergies or other atopy, having dry skin. All of these can be supportive and are important to help us lock it down, but are really not necessary. And finally, there are many associated features, and this includes things like an atypical vascular response, sometimes called white dermographism, things like keratosis pilaris, and other things like that. For mild atopic dermatitis, we will sometimes see mild erythema with pinkness, but oftentimes we'll see more of the pigmentary results that are left over, either hyper or hypopigmentation. This is very common in more mild disease. You might not be catching it in the immediate inflammatory phase, but you might be seeing some of the aftermath. Typically, we're not going to see crusting or oozing, and generally, the skin is only barely swollen or thickened. In more moderate disease, we see the redness. Sometimes it's more dull. There's often clear swelling, and the skin is thickened over time. There might be some oozing and crusting. And again, we can see some examples across different skin types because it really is a very heterogeneous disease. Finally, for the more severe patients, we're often seeing bright or deep red skin, very swollen, raised, or thickened. Oftentimes, we will see oozing and crusting, and it tends to be more widespread. That being said, it is a very dynamic disease, and a pitfall is to look at a patient on a given day and make a proclamation, but that might not always be true. They might be having a pretty good day among a sea of really bad days, so you could kind of underdiagnose them inadvertently. But on the other hand, sometimes people are having a bad flare up and might look quite severe, but it could truly be an outlier. Their average disease state might be more mild. So this makes it a little trickier, and we have to make sure we're communicating with the patient. In patients with more richly pigmented skin, there are some different features that we may see. First of all, atopic dermatitis is more common in Black individuals, and some of the morphologies that are more common in darker skin types include follicular and papular, and sometimes even nummular or coin-shaped morphology of the eczema. It can be more difficult to see the erythema, and we have to be extra careful because having darker skin literally absorbs more light, and it can be trickier to see the redness or easier to underdiagnose it to think that it's not as red as it might seem in a lighter skin type. Lichenification is often more prominent, and there is often dyspigmentation or changes in pigmentation. Sometimes it can be difficult. We can get the inflammation and the itch better, but the pigmentation alteration can last months or even years, and that can be very frustrating to the patients. So, how do we assess the severity of the disease? It turns out this is actually a tricky question because we have a number of validated tools that are used in clinical trials. And if you notice, especially more modern trials, there almost never is only one or two. There are often multiple different ways that they're measuring disease severity, impact on quality of life, sleep, all of these different aspects. And that I think is very telling. It tells us that there are many facets to the disease and that it can be a little bit difficult to measure. Some of the common ones we might hear about include the EASY score, Eczema Area and Severity Index, the POEM, the Patient-Oriented Eczema Measure, things like the SCORAD as well. We also have the Quality of Life Index and itch scores. So we often find that in a trial, we're going to use multiple things. As clinicians, it's a little bit trickier. What we tend to do, I think, more reflexively is a version of the Investigator Global Assessment. More recently, it's been validated and sort of rebranded as the VIGA, the Validated Investigator Global Assessment of Atopic Dermatitis, but it's very straightforward. It's a scale from 0 to 4, 0 being no inflammation or signs of atopic dermatitis, 4 being severe signs with marked erythema, marked induration, marked lichenification. And ideally, you can look at some slides. There's a training deck that you can calibrate yourself, but we do this somewhat instinctively. When we see a patient, we tend to be saying, are they mild, moderate, or severe? Or on this day, are they clear or almost clear? And that's really important and can be helpful. I would say it's sort of the easiest thing we can do. Many medical record systems actually have something like this even built in. They often will have a little list you can click from, but it's quite easy to call it mild, moderate, or severe and assign it a relative number. The hard part about the more advanced ones like EASY and SCORAD is that they're somewhat complicated, they're time consuming. Even I, an eczema nerd, I don't use these for my routine practice, although I know some colleagues do, but I think they're very tricky to actually use on a day-to-day basis. Typically, I will use that Investigator Global Assessment, and I really like to ask some of the key questions about sleep and how they're feeling. Honestly, those are some of the most important issues. If a patient looks good that day, but still tells you that they're miserable, I think we have to do something different, even though they look good on that moment when you see them. On the other hand, if they look terrible, but feel like in general they're doing much better, you might stay your hand and say, okay, why don't we follow up in a few weeks? Why don't you touch base? If things are not improving, if this really isn't just a little deviation from your norm, then we need to do something. But I understand that you were at your cousin's house and they have a dog and you're flared up, or I understand that you've been under a huge amount of stress and this is different than what you've seen before. So we really need to take those things into account, things like the life impact and where they're at overall in a longer time frame. We know that this is particularly important because the perception of atopic dermatitis severity often differs between patients and physicians. And in fact, we see something like about a third, so something around 32% mismatch between how patients and physicians rate their disease severity. Generally, patients report a higher degree of disease severity than physicians. And that makes sense, again, because we might be tempted to sort of say, oh, you don't look so bad today. It doesn't seem so bad. And around 20% of patients reported lower disease severity versus physicians. So it again shows us that there's some true variability. Let's move into the management of these cases, particularly the moderate to severe cases. And at the center of this whole story, there is this beautiful figure that ties the pathophysiology together. And I think this is important because it brings in the pathogenic factors and puts them together in a way that helps us understand that this is a disease of vicious cycles and, frankly, cycles within cycles. We have, as you can see, at the top, the idea that the skin barrier is damaged. We know that there's leaky skin and that allows water to come out too easily, sometimes measured as transepidermal water loss, but also allergens, irritants, and pathogens to get in an abnormal way. If we follow this around in a counterclockwise fashion, we next end on the microbiota. And we know that there is dysbiosis. The microbiome is in trouble, in part because it really relies on a proper barrier. So when the barrier gets damaged, that can disrupt the bacteria, which then in turn allows for the overproduction of different types of toxins and compounds that are driving the inflammation in the body. So we see at the 6 o'clock position, the immune system is recruited. We have lots of different parts of the immune system here, but particularly the Th2 side is really what's driving this, especially initially. We know the inflammatory cells release inflammatory mediators, IL-4, IL-13, and of course, even things like IL-31, the master itch cytokine. Not only do those go directly back and damage the barrier, causing further barrier damage, fueling the cycle, but they also, following the circle around counterclockwise, they go to the 3 o'clock position and directly can act on the nerve endings, driving itch. That itch makes people scratch. We can see that up near 1 o'clock position where we have the hand scratching. And of course, that also directly damages the barrier. Wherever you start on this vicious cycle, you can bring all the other pathogenic factors on board. And that makes it very difficult to treat sometimes. We know that it's not just skin deep, though. This is even bigger than just the skin. That vicious cycle can spiral to other vicious cycles, and sometimes we refer to this as the atopic march. And this is the idea that many patients will start usually with atopic dermatitis. They might move on to develop food allergy, and then maybe even things like asthma and hay fever. Now, not everybody gets this progression. Not everybody goes in the same order, but there really is a sense that the damage to the skin barrier and the other epithelia, like the respiratory epithelium and the gut epithelium, allow for this sensitization, and it may have something to do with our environment as well. We know that an urban environment seems to be an important risk factor for the development of eczema and allergies. One of the big questions is, could we prevent this progression if we treat the disease aggressively? And the answer is maybe. There's some evidence that suggests we can, but it's still pretty preliminary, and there are still many, many questions that remain. When we think about managing moderate to severe atopic dermatitis, there are some nice treatment algorithms. And I really think that the basic concept behind this is probably the most important part of the entire experience here, to just understand that we can use something to rescue the patient when they're flaring up. And I think this is key. Typically, we're going to use something like a topical corticosteroid, medium, maybe even a high potency one, depending on the body site and the age of the patient. For hands and feet, for example, we tend to be using a more high potency topical steroid. We can do this once or twice a day for a week or two at most. And then we want to ideally take a break and move to a maintenance phase where we're going to ideally use either a lower potency steroid, or my personal preference is to use one of the non-steroidal options. And this can be more of a prevention, maintenance, or proactive approach. And we have a number of different options. We have our calcineurin inhibitors. We have crisaborole, phosphodiesterase 4 inhibitor. We have topical ruxolitinib, which is a JAK inhibitor. And then we actually have a few agents in the pipeline. So we have the ability to use something to help prevent flares or catch them when they're very, very mild. And then if we need a rescue, we can jump to a more powerful treatment for a shorter time. We also understand that for the more severe patients, we may need to move to a systemic agent. And we tend to try our topicals first. We don't want to jump right to a systemic agent, although I should say that if somebody has 70, 80, or 90% body surface area, it is very difficult to apply topicals to that amount of skin. And many times I find that even with the best intentions, even if you're trying to dispense enough, the pharmacy might not cover it. They might send the patient home with only a 60-gram tube of triamcinolone, which for an adult is simply not going to cover 90% body surface area for 2 weeks. They're going to burn through that in a matter of a few days. So that's important to keep in mind. For these more severe patients or the more refractory moderate ones, we have a number of different things we can do. We have things like phototherapy, typically narrowband UVB light. We have our biologic agents, dupilumab, approved down to age 6 months, and its cousin tralokinumab, approved down to age 12 years. We have our new oral JAK inhibitors, abrocitinib and upadacitinib, both approved down to 12-year-olds and up. We then have our kind of legacy systemic immunosuppressants like cyclosporin, methotrexate, mycophenolate, azathioprine, and of course oral corticosteroids. But we really do try to limit the use, particularly of oral corticosteroids, because we find that many patients can go on a roller coaster. They're going to do great for a while and then flare up and sometimes be even worse than when we started. And of course, we're going to be doing this in the context of still doing acute therapy for the patients who are miserable to help them gain control, things like wet wrap therapy and even short-term hospitalization. These are tough patients, and it often takes a team approach. And many times I'm even reaching out for colleagues and talking to other people to help figure out how we can get the patient turned around. Patients receiving topical therapies tend to experience more uncontrolled disease and a higher level of treatment dissatisfaction. Now, that doesn't mean that topical therapies aren't great. They are, but we have to be careful that we're not only using them, particularly in the patients that aren't doing well. So we see many patients can be dissatisfied with their treatments and feel undertreated. Obviously, up until a few years ago, we didn't have a lot of great systemic options, so our treat to target goals are changing in real time. This is a moving target, and that's okay. That's a good sign. I think it's a sign that we're advancing. Before we had our relatively safe biologic agents, again, we really had to use everything off label. But now we have 2 biologic agents and a third about to come out. It's already been approved in some parts of the world. And these are dupilumab, tralokinumab, and lebrikizumab. And the truth is, they're all fairly similar in that they all affect IL-13. Dupilumab's a little bit different because it also affects IL-4. So that's the one that's affecting both IL-4 and IL-13, binding to the receptor, whereas tralokinumab and lebrikizumab both bind to IL-13 cytokine directly. At the end of the day, when you look at their evidence, they're all comparable, both in terms of efficacy and safety. There may be some differences between them, of course, and they're certainly not exactly the same molecule. So an individual response could be, in theory, quite different. Generally speaking, I think can be put together in the same class in your mind. Now, this is different than the JAK inhibitors, the 2 oral agents. Those are all, by the way, subcutaneous injection. The oral agents we have are abrocitinib and upadacitinib. These are JAK inhibitors, and they have some selectivity towards JAK1. We know there's 4 members of the JAK family: JAK1, JAK2, JAK3, and TYK2. And really, JAK1 is one of the key ones that we're interested in for atopic dermatitis. Not only are these medications effective, but they really can show long-term efficacy up to 5 years and even beyond in some of the more anecdotal papers. But we're seeing with dupilumab efficacy for 5 years in adults with moderate to severe disease. To me, this is the most important feature of our new medications. It's not the short-term improvement. Obviously, that's very important to the patient and to us to get somebody better in the short term, but I would argue that's not our main unmet need. We get people better, we can use many things. The hard part is keeping them there and keeping them there safely. So looking at long-term results like this, I think is incredibly encouraging, and again, helps us make that decision. It's not just for today, but it's really thinking about months or years to keep the patient in good shape. We also know that this is true for our adolescent patients and children as well. 6 to 12 years have very similar type of data we can see over longer timeframes. And that's also exciting that we can see that improvement not only in the short term, but even for sustained treatment. We even have data for dupilumab in children younger than 6 years of age and, of course, down to 6 months of age. And that's really nice to know that we can use it in very small children. But also, I find that it's helpful to talk to adults about it as well. Tralokinumab currently is approved down to 12 years of age and again has very similar efficacy and safety to dupilumab. We can see it's been studied as a monotherapy, but also along with topical corticosteroids, and it has a very nice response. And relatively quickly, we're seeing improvement on the order of just a few weeks. It separates out from placebo. And again, as you might imagine, it works across different age groups and across longer time periods, although here again, we're just seeing the 16-week data. Lebrikizumab is the third member of this family, and that one again is not currently approved, but it also binds directly to IL-13 like tralokinumab. And again, we can see a very nice improvement compared to placebo at our 16-week endpoints. And we have every reason to think that it too will be able to maintain improvement over months or years. One of the agents that's being studied is an anti-IL-31, so something that actually blocks the master itch cytokine nemolizumab. And this is one, of course, among many different agents being studied. There are apparently over 100 different treatments in the pipeline, so we definitely can't cover them all today, and I'm not even aware, probably of most of them, to be honest. But this one's interesting because it may target itch, but also does seem to target the inflammation, because we see the top curve is looking at itch itself, and we see a rapid improvement for the nemolizumab. But on the bottom, we're looking at the eczema area and severity index. And we see again an improvement here that's statistically significant. So it's probably not just itch, it's probably also treating some inflammation, but it really does seem to have some effect. And I'm eager to have this as a totally different option and a different pathway, especially if a certain patient was itch dominant or if they didn't respond to one of our biologics that targets IL-13 plus or minus IL-4. This might be something really different we could try. The good news is that the safety of the biologic agents, I think, is the key differentiating factor. Not only are they very effective, but the common adverse events, I think, are relatively compact and relatively easy to talk about with our patients. So for dupilumab, injection site reactions and conjunctivitis, so itchy red eyes; tralokinumab, upper respiratory tract infection and conjunctivitis; lebrikizumab, very similar, conjunctivitis again; headache, hypertension, injection site reaction and herpes infection; and nemolizumab, nasopharyngitis, upper respiratory tract infection, worsening of atopic dermatitis, increased CPK, and injection-related reactions. So very similar. You'll notice that with the IL-13 group, Dupi, Tralo, Lebri, they all have conjunctivitis featured, and we think this is a feature of IL-13 inhibition. The most important thing is to have the patient and the family on board. It has to be a shared decision-making process. And this can be difficult for some situations, and sometimes it's very easy. It comes naturally. But whether it comes easily or if it is a challenge, we really have to make sure that we are sharing the information to the best of our knowledge. And I think with humility, understanding that, especially with a lot of these new things, I acknowledge that we don't know everything about them. And yes, they're pretty new. And I want the family and the patients to have a chance to make their decision, to tell me what are their interests, what are their goals, what are their fears. And then I like to go back and forth. We try to pick something and then we give some feedback and we discuss if we think this is a good approach. I also think it's really important to explain that it's not one and done. This is a relationship. It's a journey. And we take some time explaining, listen, if this doesn't work out, we will stop and we'll do something different. We'll go a different way. Part of the complexity of this is that each treatment has a lot of nuances, whether you're talking about the biologics and the difficulty of obtaining it. These newer medicines are expensive. They're sometimes hard to access. We also have to make sure they're comfortable doing an injection at home. All of those are self-injected. And that can be striking for some families or shocking where they say, wait, I'm not coming in to get this. And sometimes we will. We'll allow them to come into the office and we can support them with that. If it's one of the pills, for example, one of the JAK inhibitors, there's some lab monitoring. We have to talk about the boxed warning. And we didn't get into that today, but that's really important. We don't want them to be off-put when they read things like it is associated with a higher rate of malignancies and infection and even a higher mortality rate from all causes, major adverse cardiovascular events. One can imagine this can be pretty chilling to read this, and especially if they hadn't talked about it in clinic. I've had the story where patients say, the doctor gave me this prescription when I picked it up. Then I learned about all these things and I was very frightened. So we have to actually spend some time counseling about the medications to understand that we have to make it a good fit. A framework that I like to use thinking about different medicines, I abbreviate it to EAST, EAST, efficacy, accessibility, safety, and tolerability. And sometimes I'll even add on an R at the end so we can do it a star. And R can be for remittive aspects of the treatment. So some of the most exciting work right now is that certain therapies may, after a period of doing well, sometimes for 6 months or a year, they may be able to be decreased in their dose or even stopped altogether, putting patients into a relative state of remission. That's incredibly exciting. We still have a lot to learn about that, but what's really encouraging is that tralokinumab, for example, actually has within the prescribing information the ability to decrease the frequency from every 2 weeks to every month if the patient's doing well. So we're already seeing this kind of thinking enter into the discussion. So we can talk about the efficacy. How fast does it work? How well is it going to work? Is it going to continue working for a long period of time? And for example, that would be a great opportunity to talk about a biologic agent versus, for example, oral prednisone. Oral prednisone is going to work super fast within days. It's going to have people better. It's going to work extremely well for most people. They're going to be cleared up. But the problem here is the duration. We can't do it for very long. Otherwise, it gets extremely dangerous. And I would argue it's in many ways the opposite of remission. Many people, at least a significant proportion of people, a sizable group, can have a rebound flare up. And even if they don't, it can be each time you do it, it's a little bit like playing Russian roulette. So that's important to talk about that efficacy and explain those nuances. The accessibility is important too. It's not just the cost. You can look up a price of a drug and say that's ridiculous or that's great, but that actually has, I think, very little balance and meaning on a patient's decision, because that doesn't mean what they're going to pay. And frankly, it doesn't even really mean what the system's going to pay. Sometimes people say, well, we have to be good stewards. And I think we have to, but looking at the number on the sheet of paper often does not reflect what the insurance company is going to pay anyways, because of the existence of things like rebates and all these other types of programs. But the cost, the route, the time that it's going to take them. So phototherapy is a great example. It may not be accessible very much because they have to come into an office 2 to 3 times a week, and it can be very expensive, even though it's covered by insurance. Most of my patients have to pay a copay for every single phototherapy treatment. The safety aspect is really important as well. It's not just the things that can impact their health, but of course, it's even some of the things that are concerning. So the risk of infection, it's very unlikely that someone's going to have an infection if you look at the absolute numbers. For example, in the JAK inhibitor studies, those numbers are extremely low, but it's not zero. So the potential for safety is really difficult for us to deal with. And patients will ask me point blank, what are the risks? How risky is it? And the truth is we don't know, right? When we're looking at a smaller data set, we can only say so much. There is a confidence interval, and it doesn't necessarily predict what's going to happen to an individual patient. Of course, for the patient that has a safety issue, well, now they're in the 100% group. They really got it. So no matter how rare it is, if it happens to that patient, our job is to be human. We're not a computer. We're not just giving them some number. We really have to take care of each patient. And then finally, the tolerability. Different than safety, these aren't the dangerous things, but these are the things that can cause trouble. With cyclosporin, I've seen hypertrichosis. They've grown hair all over their body. It's very, very unpleasant, and people want to stop. With our biologics, we've talked about that conjunctivitis. Typically not a dangerous side effect, but it can be very, very difficult to tolerate it. With the JAK inhibitors, acne. We have patients who can develop some acne. So again, not a life-threatening condition by any stretch of the imagination, but it sure makes it less pleasant, less tolerable. All of these features we want to keep in mind, we want to deal with. And of course, we want to have close follow-up so that we can continue to refine and make sure that we can fine-tune it to the patient's individual needs. That personalization process is really important. So to summarize, atopic dermatitis presents differently among children versus adults, and of course, among different skin types. Family history and atopic disease really raise the risk of developing atopic dermatitis, but certainly aren't necessary. Many patients don't have any relevant family history. The perception of atopic dermatitis severity can really differ between patients and providers, and we see it can go in either direction. And this highlights a need for enhanced communication and the use of simple, effective tools when we're trying to assess the severity. Patient caregiver education is critical in making a shared treatment decision, particularly when stepping up from moderate to severe atopic dermatitis treatment with use of systemic medications and when managing patient concerns. We talked about that this is going to be a longitudinal relationship and things may change. Finally, targeted biological therapy. And we've talked about some of the different biologics, including dupilumab. These really have been proven safe and effective for patients of a huge age range. For dupilumab, down to 6 months of age with moderate to severe refractory atopic dermatitis. For tralokinumab, 12 years of age and older. And we even have other targeted agents in development, lebrikizumab, nemolizumab, and more. That ends our discussion for today. I hope you found this activity informative and useful to your practice, and I encourage you to participate in other modules that are part of this curriculum. Thank you very much for participating.
Hello, this is Dr. Sean Quattro from the Johns Hopkins University School of Medicine. Welcome to this educational activity on Prurigo Nodularis. This activity is part of a 4-part curriculum titled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy, focused on moderate to severe atopic dermatitis, Prurigo Nodularis, chronic urticaria, and Bullous Pemphigoid. You can access the full curriculum at PeerView.com. So we'll get started by discussing the diagnosis and also exploring the pathophysiology of Prurigo Nodularis. Prurigo Nodularis, or PN, is a distinct inflammatory skin disease, and it's characterized by intense itch or pruritus, and many of these elevated, firm, hyperkeratotic nodular lesions that can present most commonly on the arms and the legs, but can be in other areas as well. So there have been several studies on the estimated prevalence of PN, and what's interesting is that each year new studies are done, the prevalence seems to be increasing. I believe that's because we have very poor disease awareness of PN at this time. So one of the studies said around 87,000, and then some of the more recent ones are even around 200 or 300,000. So it's very interesting that the prevalence of PN seems to be growing as well as we get better awareness of the disease. So the clinical picture in patients with PN can be very heterogeneous. So you can see that some of the lesions are smaller, even more papular, a few millimeters in size. Some of them are much larger, even closer to a plaque, or really a deep-seated nodules. You can see that in skin of color patients in particular, you can oftentimes have dyspigmentation. So sometimes you can have hypo or hyperpigmentation from these lesions. And dyspigmentations, especially that pink color, is something we really seek to avoid because oftentimes there's no way to reverse it. And so we want to make sure that we have early therapeutics for our patients. So you can see the heterogeneity of the lesions. What we've observed is in skin of color patients, oftentimes the lesions can be more hyperkeratotic in nature as well. So these nodules are usually symmetrically distributed on easy to access areas, arms, legs. Areas that are less commonly affected are the face, the palms, the soles, the scalp, and the genitals. Those are just not as commonly affected with PN. And there can be many of these different phenotypes. So you can have true nodules. You can also have these raised plaques. You can have shallow excoriations. So I've been fooled a few times. Folks sometimes have just excoriated lesions and can sometimes actually be mistaken for having excoriation disorder. So that's another phenotype. These lesions can be ulcerated, oftentimes from the chronic scratching. You can actually have that outer layer of the epidermis that can fall off, and you can have very ulcerated areas that can be very tender. Oftentimes we have these scars in these patients where hyper or hypopigmented scars and remnants from earlier active lesions. And what you'll oftentimes see in the exam room is that there's clinical signs of active scratching, picking, rubbing. I can remember many instances walking into a patient room and seeing these lesions bleeding actually the blood even falling to the exam table because it's that intense itch. And so you can pick up the signs from the clinical exam if the disease is very active, which it usually is untreated, that many of these lesions will be open, excoriated. So the itch or pruritus can also be accompanied by other sensations. So it's not only itching, but it can be burning, stinging, pain. Sometimes folks may even report crawling sensations as well. And actually, my lab and others have done studies looking at the neuronal distribution in the skin, so the distribution of nerves in the skin, and found that even in lesional and non-lesional skin, there seems to be something there, disorganized architecture as well, that could convey some of these other sensations that patients are experiencing. So putting it all together, pruritus or itch is really the dramatic source and driver of diminished quality of life in these patients. That relentless itch can lead to sleep disturbance, so trouble sleeping. And as we know, if you have trouble sleeping, that can oftentimes lead to the development of other psychiatric conditions, comorbid diseases, anxiety, depression. What's interesting in this patient population is that there's actually disfiguring, visually apparent nodules. And patients oftentimes withdraw from social interactions or avoid these interactions due to embarrassment over the lesions. I can tell you many of my patients have reported that, they just didn't feel comfortable going out on a date, meeting their friends. Folks oftentimes have avoided them because they thought what they may have was infectious. So it can be very significant, the burden. And that can only further exacerbate depression and anxiety in these patients. So it very much so is a difficult disease to treat. And when our group actually did a study looking at the overall impact of the quality of life in Prurigo nodularis patients, what we found is that it's nearly as severe, the overall impact, as folks who are undergoing hemodialysis, who've had a stroke, who have chronic heart failure. That's the immense burden that this disease has. And it's also a great opportunity for us to really intervene in the care of these patients. So impaired quality of life, sleep deprivation, missing work and school. We talked about the emotional and social impact. Those are all many of the dimensions of helplessness and quality of life impact that these patients experience. What's interesting is that there can oftentimes be comorbid conditions. So some folks think, oh, well, if you have Prurigo nodularis, there has to be an underlying cause. I would slightly disagree and say Prurigo nodularis is a unique phenotype, a unique disease, just like psoriasis and atopic dermatitis. It has a very unique disease presentation. But these patients, similar to psoriasis patients, may be more likely to have certain comorbid conditions, such as diabetes, much more common in Prurigo nodularis patients. My thoughts are that potentially diabetes can lead to a subclinical neuropathy that can actually affect the nerves and trigger some of this itch-scratch cycle that we are seeing. Chronic kidney disease, similarly, also cardiometabolic diseases and heart failure. We also know that hepatitis and HIV are more common in PA patients. In particular, African-American patients with HIV tend to have a greater appearance of prurigo-like nodules, and that tends to associate with a greater degree of fibrosis and fibrotic diseases in African-American patients. Also, if there's very new onset Prurigo nodularis, you may consider a non-Hodgkin lymphoma. That's usually more new onset PN or itching. And so that's something to watch out for if it just kind of comes up out of the blue, maybe if there are some B symptoms, fevers, night sweats, any of those things. So although some of these conditions can be associated with the disease, we still haven't narrowed down the precise relationship of these different diseases to the emergence of PN. So when we look more at the pathogenesis of Prurigo nodularis, you can see here that there is an interplay of the nerves or the neural system and the immune system. So you'll see that itch sensation is transmitted through the nerves. So these nerves go all the way out to the dermis and epidermis. They're thinly myelinated A delta fibers and unmyelinated C fibers. Their cell bodies are located in the dorsal root ganglion. They cross over through the spinal cord up to the brain and actually present and project to different brain areas as well. So this is why if you're very stressed out, that can trigger and worsen your itch that you have. And also local factors can then be transmitted this way. So in addition to the nerves, we know the immune system is very important in Prurigo nodularis. When you look at the distribution of the nerves, they're in close proximity to many immune cells. So T cells, mast cells, eosinophils, many of these different cell types are then subsequently releasing inflammatory neuropeptides, cytokines, Actually, the nerves can release neuropeptides to stimulate from these immune cells the release of cytokines, and the cytokines can actually then also influence the release of neuropeptides. So the neural and the immune system are both jointly involved in this disease process. PN does have a differential diagnosis. I would say mostly it's a disease that can be diagnosed clinically at the bedside if folks have these hyperkeratotic skin nodules or other lesions with a chronic itch and signs of scratching. Other things to think about, some of this is nomenclature. So perforating disorders like Curley's disease oftentimes can happen in the context of diabetes or chronic kidney disease. In my view, many of these perforating disorders have very similar pathophysiology and can be lumped into Prurigo nodularis. Hypertrophic lichen planus oftentimes also has an interface dermatitis, can be thickened, especially in African American patients. Oftentimes it may have more of a violaceous hue to it. Atopic dermatitis patients oftentimes have secondary thickening of their lesions. So even younger folks, children who have atopic dermatitis are more likely to have small raised bumps or papular lesions. And this also holds true in adults. The key is you see areas of classical eczema at cubital popliteal fossa, also in African Americans, the extensor areas that are commonly affected. And then you can have some of these secondary nodules as well. Then there's some more rare diseases like Bullous pemphigoid, Prurigo pemphigoides, where you could potentially have this presenting. I usually don't go down working this up unless something seems a little atypical. There's presence of urticaria lesions or non-response to traditional therapeutics. That's why I wouldn't recommend a biopsy off the bat. Another reason not to recommend a biopsy off the bat is it can be incredibly nonspecific. So actually, I had a patient who's one time was referred to me for the management of about 200 squamous cell carcinomas or keratoacanthomas, and that's what the dermatopathologist had read it as, but is actually just PN. So that leads us to another differential, the keratoacanthomas as well. Arthropod bites or scabies, you usually have the right clinical context, very acute, different morphology, like an amyloidosis, again, different morphology localized to certain areas as well, like the lower legs. The greatest confusing factor here that leads to misdiagnosis is excoriation disorder, because the lesions can oftentimes be so excoriated. What I will say is that many of these patients have actually responded to immunomodulator therapy. So I do believe that it's important to understand that there can be an excoriated or ulcerated phenotype of Prurigo nodularis, and understand that these patients may respond still to immunomodulator therapy. So I'm using immunomodulator therapy also as a way to differentiate who may actually fall into a different category of disease. So those are all important things to consider. Again, you don't need to have a biopsy, and sometimes a biopsy can be entirely nonspecific in these situations as well. So other ways to distinguish between PN and other diagnoses, if you do a biopsy, some of the characteristic features is very thick orthohyperkeratosis and pseudoepitheliomatous hyperplasia, focal parakeratosis as well, hypergranulosis in the epidermis. You also traditionally have papillary dermal fibrosis, these very vertically arranged collagen fibers that associates very well with fibrosis that you're seeing clinically. This disease is also very vascular, so you can see increased numbers of capillaries in these patients, and then mixed superficial, perivascular, interstitial infiltrates as well. So the skin biopsy, the H&E, again, not something we recommend up front, but something that certainly can be performed if needed. And also the direct immunofluorescence is another thing that potentially can be done. Skin scrapings for things like scabies, really got to use your clinical judgment. And if folks have, say, burrows between the web spaces of their fingers, that might be a sign, very acute onset. Other family members in the household that also have this type of itching may be another clue for you that could be the underlying disorder. So the diagnostic workup for Prurigo nodularis, and I want to start more broadly. Why do we even do a workup for Prurigo nodularis patients? Well, I'll share a recent study that our group actually led. It was the first genetic whole exome study. And we actually were able to make a polygenic risk score or a measure for genetic risk if folks are more likely to have the presence of these nodules or skin lesions or just itch on normal skin. So that's why your analogy of Prurigo nodularis is to chronic pruritus of unknown origin or itch that's generalized on non-lesional appearing skin. So that's why we're going to be doing a similar workup. So the first thing is we look at patients, let's see the extent of the prurigo nodules. In some of the clinical trials, they use investigator global assessments, which you don't have to do, but can be helpful also with getting drug approvals with new therapeutics. So 0 is 0 lesions. We also know 1 is between 1 and 6 of these lesions, or 1 and 5. An IGA of 2 is 6 to 20. An IGA 3 be 20 to 100. IgA4 would be hundreds of nodules. So it's good to assess the number. Also the firmness. Some of these lesions can be incredibly hyperkeratotic, firm, thick lesions. So that's important to assess when you're looking at these patients. I think assessing itch intensity is important because there's more to this disease than what you see. So one of our lab studies had shown that in these patients, there's inflammation both in lesional skin and in non-lesional, normal appearing skin. There's still some more subclinical inflammation going on. And that there's actually inflammatory mediators in the bloodstream. So we saw that there's different immune cells like gamma delta cells, T cells, natural killer T cells, other types of inflammatory T cells that are circulating in the bloodstream. We know there's also increased levels of several cytokines. We found increased IL-13 levels. Other folks have found IL-31 levels as well. We know that there can be increased IL-22 also released from peripheral blood mononuclear cells. So we do know that a lot of immune mediators and inflammation can be present in PN. The reason that's important is when we asked our patients, where are they itchy? Actually, 2/3 or 67% of patients reported that they're itchy in the nodules and in the normal appearing skin as well, which truly highlights that this disease is systemic in nature. So that's really important to keep in mind. It's not just what you're seeing. You can't assume that we can appreciate patients' disease burden. So one simple thing that I do is I ask folks, hey, what's your worst itch that you've had in the last 24 hours, where 0's nothing or no itch, and 10 is the worst unmanageable itch they've had. And that can be helpful, especially 7 and above. Sometimes there is a mismatch. Some folks can have, less nodules, maybe not appear as firm, but it can be incredibly itchy, even in areas that aren't affected. So I think that can be very helpful for you. And then other aspects of disease burden, anxiety, depression. I know we don't have much time in our clinical visits, but there can be opportunities to inquire about this and also help get folks the help that they need. We know that these patients do have a lot of comorbid anxiety and depression. Who wouldn't if you can't sleep at night because you're itching so much? I think that's an important thing to realize, though. It's not necessarily that there's any kind of underlying psychological condition. It's that this is a very debilitating disease. If you can't stop itching, you can't sleep, and that can lead to these conditions. So for lab tests, things to think about: complete blood count with differential. Why do you do that? Well, you want to look for any hematologic or blood dyscrasias. Very, very uncommon, but can be helpful. And then liver and kidney panels, just to make sure there's no liver or kidney involvement. Again, PN and the workup for PN is very similar to the workup for chronic itch or chronic pruritus, so you do a similar thing. I usually just order a complete blood count and a comprehensive metabolic panel. Then we do know that some conditions are slightly more common in PN patients, so thyroid irregularities. It's still unclear if that's necessarily just associated or the driving factor, but I would say getting a TSH or thyroid function testing is something that can be performed because there is an easy fix now that we actually have thyroid replacement therapies, and we've had them for quite a while, so that is reasonable to look up. Diabetes assessment, I think, is really important. So either a blood glucose in your comprehensive metabolic panel or hemoglobin A1C. It is very surprising the number of patients with PN that actually have elevated blood glucose. It's very staggering. So that's something you want to keep in mind. And I actually think if folks are working on their holistic health, that'll help their skin also. So if we can identify that and actually direct them towards a primary care physician who can start them on therapy, they can be encouraged to make lifestyle changes as well. That can only be helpful for us in the management of our patients. And then, as we mentioned earlier, there are some infectious diseases that are uncommon, but more likely to happen in PN patients. Still not super common, but something to keep in the back of your mind. So HIV and hepatitis B and C. I'd say these aren't necessarily mandatory in all patients, but you want to assess for risk factors, share decision-making with your patient. If they may be in an increased risk, that's certainly something that can be done. Additional tests or ways to think, if they've had the itch, especially for less than 3 months, but if it's less than a year, we definitely want to make sure there's no fevers, chills, night sweats, any other sudden weight loss or other things that may be giving us some concern or pause for malignancy. And they should absolutely be up to date on age-appropriate malignancy screening in these patients. Those are really important factors for these patients. So let's dive a little bit deeper. I have a photo here now into lesional skin of Prurigo nodularis patients. So you can see that there's this thickening, orthohyperkeratosis, hypergranulosis as well, epidermal hyperplasia, very significant thickening. And you can also see that in the dermis, upper dermis, there's an immune infiltrate, T lymphocytes, eosinophils, and you can see the collagen fibers are arranging. So definitely some fibrosis as well that's going on. When you assess these patients, I had mentioned the worst itch numeric rating scale is also the pruritus numeric rating scale. I like that because this is how folks have lived at the worst moment in the last 24 hours. You could also certainly get an average itch for them. There's other things like a visual analog where you actually mark it on a line. There's a Prurigo activity and severity score, which has been used in clinical trials, may not be able to do in clinic. The dermatology life quality index, again, used in trials. Those are the itch recall, but may not be most appropriate for a very quick clinic. So I know that in dermatology, we're seeing patients at a pretty quick pace. So that might not be necessarily possible. But I think you can ask their itch, what's the worst itch you've had in the last 24 hours? That's reasonable. So let's shift now to targeted biologic therapies in the management of Prurigo nodularis. So the goal of treatment is to reduce the itch, pruritus, interrupt that itch scratch cycle, and heal the nodular lesions. So actually, as a member of this panel in 2021, this is before there was approved therapeutics. This paper got accepted. Actually, it's now pretty much out of date, but what we had said was there are therapeutics in PN that are modulating both neural and immune axes. So things like topical steroids, intralesional steroids, which are actually more effective in PN compared to atopic dermatitis or psoriasis, because as we saw from the histopathology images, the lesions can be very hyperkeratotic and the inflammation is present in the dermis, those upper layers as well. So it's very difficult with a cream to penetrate that layer of hyperkeratosis. So the intralesional injections can be helpful. I haven't had much success with topical anesthetics, capsaicin, or any of these other drugs, but they were mentioned. Narrabin, UVB phototherapy, methotrexate, cyclosporin. We hate these nonspecific immunosuppressants, especially in the PN patient population that has a lot of comorbidities, especially kidney disease. That would really give me pause in folks, especially methotrexate, cyclosporin. Many of these patients also have hypertension as well. So something important to think about. Narrabin, UVB, or Puva are certainly reasonable options. They can just be very slow sometimes, and sometimes they're good adjunct to therapies as well. With monotherapy alone, it can take quite a while. And there's some off-label things like gabapentin antidepressants, very poor data for any of these things, but some options. This was made before dupilumab was approved, but dupilumab, and then we have IL-31 inhibitors in development, some JAK inhibitors off-label, and you can see some other drugs listed here like thalidomide. I actually used to do this several years ago before we had approved therapeutics, which is a very dangerous medication. So I'm glad that we're now entering a new era with new therapeutics. So let's shift now, since this is out of date. In 2022, we had a pretty big finding. The US FDA approved dupilumab for the treatment of PN and really cemented this as a therapeutic option for patients who have Prurigo nodularis and are uncontrolled with their disease. And this approval was based on the results of the phase 3 Liberty Prime and Prime 2 trials. So actually, dupilumab was first approved for atopic dermatitis in around 2017. And there started to be some case reports, case studies, as often happens in dermatology, noting that there was improvement in Prurigo nodularis with dupilumab therapy. So these Prime and Prime 2 trials were conducted. You can see the N there of 311 patients. Similar dosing to atopic dermatitis studies, so 600 milligrams, the loading dose, the 300 milligrams, followed by 300 every 2 weeks. And the endpoint here was at 24 weeks, and also had background topical steroids or calcineurin inhibitors. The primary outcome was the proportion of patients who had a 4-point or greater improvement from baseline in this worst itch numeric rating scale. Also, key secondary outcomes, we discussed the investigator's global assessment score, so 0 to 1 at week 24, which is pretty high bar, and then also the proportion of the patients who reached both metrics. So both of these trials, as you can see here, had a 2 to 4 week screening period, 24 weeks treatment, also 12 weeks follow-up, had their itch assessed at these different visits, also the IGA where you can see the nodules. Again, we're going to define success here as 0 to 1. So that's really a high bar, less than 6 nodules. And to enroll, you had to have a worst itch of 7 or greater and an IGA of 3 or 4. So at least 20 nodules or greater. And both of these trials wanted to demonstrate safety and efficacy. So as we can see here from the pooled results here of this data that we had improvement in the worst itch numeric rating scale in dupilumab versus placebo. We also had an IGA score that was significant. You can see at week 12 and week 24. In particular, at week 24, you already had 46% of patients or so who had the IGA 0 to 1. And then you had a big contingent of folks who had both the IGA and the itch improvement. But almost 60% of patients had that 4-point improvement at week 24. And you can see just how significant it is. At week 12, it's increased. At week 24, it's increased. And in real world experience, continued to have greater improvement as more time has gone on in these patients. So things to think about in dupilumab treatment patients, the improvement of skin lesions usually lags behind the itch, and that's just the natural history of the disease. You scratch your skin, you get a thickened nodule, and it takes a long time for that to melt, but the itch happens more quickly. Itch is the best real-time indicator that we have of disease severity. So if the itch is improving, then you know and you can feel confident that we're on the right track. So in this trial, this mirrors the natural history that we appreciate. Itch improved, and then the nodules improved as well. And the post-hoc results also support dupilumab efficacy despite prior use of immunosuppressants, phototherapy. So it can indicate that even PN with greater disease severity that's been refractory to treatments, that dupilumab can be a very good option in these patients. So we know that about dupilumab. It's been FDA approved, the first FDA approval for Prurigo nodularis, and a big victory for patients to have a therapeutic option that's available. We also have a number of other agents that are going on. So the agent that's the farthest along right now is nemolizumab. Nemolizumab is a monoclonal antibody targeting IL-31, which is a rapidly itch-inducing substance IL-31 is. And there's actually a phase 2 study, and there's a phase 3 study published showing the efficacy of nemolizumab in patients with Prurigo nodularis. So that's very far along. So we have 2 phase 3 trials, both showing efficacy and fast on itch relief. Also, abrocitinib, this is actually a study that my group led in just 10 patients with Prurigo nodularis and itch of unknown origin with positive results. Abrocitinib is a JAK1 inhibitor. We also have another JAK1 inhibitor from Incyte, ofacitinib, as you can appreciate here, which has a global phase 2 study ongoing. There's some positive data for rixarilumab, which is an oncostatin M receptor beta inhibitor, and that's related to oncostatin M or OSM, which is also another itch-causing substance. There's also some data for drug nalbuphine. So this is a synthetic opioid agonist-antagonist, so the kappa and mu opioid system. We know that if you're an agonist on kappa opioids or you increase the kappa opioid tone, then you're usually more itch relieving. But sometimes you can have central nervous system effects, dizziness, all of that. So there was some positive phase 3 data, a little bit more modest, and some side effects to watch out for. But it's very exciting to have these agents in therapeutics. There are actually other agents that are at earlier stages in development as well, such as tryptase inhibitor as well. So to summarize, the goals of PN treatment are to reduce the itch or pruritus. That's number one. Once you reduce that itch, things get better. We want to interrupt that itch scratch cycle, heal the PN lesions, and improve patient quality of life. The treatment for PN is undergoing a rapid revolution, and it's begun to evolve with the approval of targeted biologic therapy for the first time with dupilumab in 2022, and then having other agents that are very close, like nemolizumab, that's very close as well, with 2 phase 3 trials completed, JAK inhibitors, and other agents also in development. So that ends our discussion for today. I hope you found the activity informative and useful to your practice, and encourage you to participate in the other modules that are part of this curriculum. Thank you very much for participating.
Hi, I'm Dr. Adam Friedman from the George Washington University School of Medicine and Health Sciences. Welcome to this educational activity on chronic spontaneous urticaria. This activity is part of a 4-part curriculum titled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy. Focus on moderate severe atopic dermatitis, Prurigo nodularis, chronic spontaneous urticaria, and Bullous pemphigoid. You can access the full curriculum at PeerView.com. So let's start off by discussing the diagnostic criteria and disease burden for a disease I would say is probably underappreciated, under-recognized, but certainly we should not underestimate the burden and the impact this condition can have for many different reasons, which I'll certainly get into. The good news is we do have some really strong diagnostic criteria that can help guide us down a path towards, for example, chronic spontaneous urticaria versus urticarial dermatoses, of which there are quite a few. And so it can be a diagnostic challenge, and there are very simple questions we can ask our patients, several bedside diagnostics that can really lead us down the right direction to ensure we have the right diagnosis and therefore ultimately the right management strategy. So let's start by defining what is urticaria. Now, as I mentioned, it is poorly understood, though I would throw out there, anytime you start to get industry interested in a disease state, an active pipeline, all of a sudden, we start learning so much about the underpinnings of the pathophysiology. And we'll dive into, historically how we thought about urticaria and how that understanding has expanded tremendously. But I would argue that this condition is really underestimated in many different directions. And at the crux of it, when we say urticaria, we're not just talking about chronic spontaneous urticaria, but we're talking about that division, that line in the sand between acute and chronic, and then under chronic, there are different subtypes. But regardless of the type, there are some common threads that are true throughout. So first and foremost, sudden onset. And this really gets to the burden. I'll talk about this in a moment. But the fact that this can go 0 to 60 in nanoseconds is really unique to this collection of diseases. These are dermal edematous plaques, so there really should be no surface change. These are pruritic, and I'll get into also pruritus because there are many flavors of pruritus. But these are pruritic wheals, these kind of edematous, fluffy dermal plaques with or without angioedema, which I like to say is kind of like a deeper version of urticaria. And this, I think, is the most important piece that will resolve within 24 for, of course, urticaria hours, or a little later, 72 hours when it comes to angioedema. Now, this is the first kind of distinction because how we frame things to our patients can make or break the diagnosis. If you say to someone, does this go away in 24 hours? They may think you're inferring the entire process. They'll say, no, this has been going on for weeks. You'd be very specific and say, that spot on your arm right there, will that be there tomorrow? If I drew a circle around it, would there be something in the middle of that circle? And that's how we're delineate between urticaria or urticarial. Now, I really don't like the term wheal because it suggests that the plaques are always going to be perfectly annular and fit some textbook definition, and that's absolutely not true. I find that often urticaria, yes, can be maybe nummular or annular, but it can be arcuate or serpiginous. It kind of follows its own path. It beats to its own drum. So I think if you focus on the more important elements of the description, that these are dermal, erythematous, edematous plaques, and of course that timing, that I think is more important than focusing so much on the wheal and flare. Now, I mentioned that pruritus. Well, in thinking about this overall curriculum, the itch of different diseases can really define those diseases. So let's talk about atopic dermatitis, all right? This is an itch that feels so incredibly good to scratch. And that feeds into that ongoing scratching. Even though patients hate to scratch, they also love it. This positive feedback, this itch that feels so amazing to scratch versus Prurigo nodularis, which has a kind of constellation of features. It's like a come-all from a sensation standpoint of itching, burning, creepy, crawly, you name it. And it hurts and itches at the same time, especially when one scratches. Now with urticaria, it's a little different. It is itchy, but it's also a burning itch. I realize it says sometimes burning sensation. I disagree. That burning is almost in parallel with that itch, which really makes this kind of stand out. But once again, I want to harp on the fleeting, the ephemeral kind of element of this disease in that an individual lesion should last no longer than 24 hours. Now, angioedema, once again, I kind of think of it as a deeper form of urticaria. And in essence, it is that vasodilation, that vascular permeability is just deeper in the dermis. Comes on real fast, just like urticaria. You most likely will not appreciate erythema, maybe more of pallor, maybe more of blanching in the area, maybe peau d'orange due to that infiltration of dermal fluid. Though, to be fair, even with urticaria, which might be more superficial, depending on skin tone, you may not see the flare. You may just see the pallor of that vasoconstriction due to the edema, that kind of pressure on the vessels, that blanchability due to that dermal edema. So don't rely just on one feature to make the diagnosis. With angioedema, the erythema may just be not visible because it's too deep, but even with urticaria and darker skin tones, you may not appreciate erythema just because of that skin tone. In a similar fashion, itchy, tingling, burning, maybe fits a little bit more with that Prurigo nodularis pruritus, but I think that itchy, burny sensation certainly rings true. Tends to take a little longer to resolve than urticaria, so up to about 72 hours versus 24 hours with urticaria. Now, how do we classify urticaria? So I honestly would love to know who decided to create this line in the sand, less than 6 weeks versus greater than 6 weeks when it comes to the classification of acute versus chronic urticaria. Spending just a moment on acute urticaria, roughly about 80% of people will have at least one bout of acute urticaria. And when thinking about etiology, because when you talk about chronic spontaneous urticaria, by definition, it may not be possible or rarely possible to identify an etiology. With acute urticaria, meaning urticaria that is occurring less than 6 weeks, that plaques or papules are coming and going every 24 hours for less than 6 weeks, the mantra is food, drug, or bug. Whether related to food, an infection, which is probably more common causes, or drug, you may be able to hone in on it. But when you get past that 6-week mark, then the likelihood of identifying the underlying cause is pretty low. Though your patients are going to want you to. They're going to beg you for a reason. They're going to feel vindicated if you can just give them why this is happening. The reality is you often can go down a rabbit hole that really elicits no pay dirt, unfortunately. But once again, you have to really elicit a good history, because when we think about that greater than 6 weeks, it's not continuous 6 weeks. Rather, it's 6 weeks altogether. So someone could have 3 weeks here, 2 weeks off, 2 weeks here, 4 weeks off. It's over time. If you collate about 6 weeks or more, then you're in that chronic urticaria category. So it's important to really elicit that history. Now, when we start to get into the chronic era or the chronic phase, we can start to divide into maybe two broader categories: spontaneous or inducible. We're really going to focus on spontaneous urticaria, but it's important to think about inducible urticaria as well. One, because that's really fun to elicit at the bedside. Let's be honest. This is one of those bedside diagnostics that make us look like superheroes in terms of making a diagnosis and using very simple tools to do so. The other piece of it is that just because someone has one form of chronic urticaria doesn't mean they can't have others. Often patients with chronic spontaneous urticaria also will have inducible urticaria. So it's important to do some of these inciting tests at the bedside, even if you feel very confident about a diagnosis of chronic spontaneous urticaria. So in defining these, CSU, chronic spontaneous urticaria, will be spontaneous appearance, no external factors driving the emergence of these wheals or plus minus angioedema for greater than 6 weeks with no underlying cause. And that's important. Remember, patients might want to know the reason, but there may not be one. I like to say idiopathic, which used to have that in the title of this condition. It's a fancy way of saying we have no idea. Whereas inducible urticaria, this could be due to scratching, temperature, increased body temperature like cholinergic urticaria, water exposure, vibratory pressure from maybe a tight belt or a heavy backpack. And so there are different things at the bedside you can do to elicit these. But once again, if you pick up on one, I think it's important to at least ask about the others, if not do these bedside testing as well. Burden of disease. I think we're in a day and age where we all appreciate that dermatologic disease, visible disease states, have an incredible burden on life. Every aspect of life. I really think that we are well beyond that initial phase of trying to prove that point to the masses. We all get it. Even the FDA gets it. The one thing I really want to hit upon with this slide, though, is there's something unique to urticaria compared to other diseases. And it goes back to that Lamborghini fast 0 to 60, in that patients with CSU are just waiting for that next shoe, not just to drop, but to avalanche. All right. It's not like atopic dermatitis, where, as the word eczema infers, boiling up. This isn't boiling up. This is flash fried. Patients could be sitting there minding their own business, and all of a sudden it could be covered head to toe in urticaria plaques. So that sudden onset, that waiting for really that massive explosion, adds a unique level of burden to quality of life with these patients versus the many inflammatory and neoplastic skin diseases that have tremendous burden on quality of life. So just something to consider when approaching these patients. Now, there are lots of ways to measure quality of life. These are often used as research tools in clinical studies. Do I expect anyone here to utilize these in your practice? Well, certainly if you're even IRB approved study, be my guest. But the reality is you're not going to use these. These are somewhat onerous, but it's important to know they exist so that you can interpret the data when looking at new publications relating to burden of disease or new therapies, or at some point we might need to record some of this information in our charts from a pragmatic standpoint in terms of identifying severity of disease. However, we'll get into this a little bit later. There are some pretty easy tools to help define severity of disease as well as monitor progression over time in response to certain therapeutics. Now, there can be associated symptoms, and I think the first visit you have with a new CSU patient should be a bit lengthy. It should be more of an interview, not just in terms of eliciting potential inciting factors, history of individual lesions versus overall, But there can be associated clinical symptoms. Certainly, there are some comorbidities, though I think that there is a gap in our understanding of those comorbidities, so ripe for the picking when it comes to doing more research. But there can be associated symptoms like joint pain. For example, there is an urticaria arthritis syndrome that's relatively rare, but you can see joint pain associated just with deep dermal edema. So angioedema overlying a joint space can cause stiffness or joint pain. The release of histamine broadly can have a lot of different physiological impacts. And when you think about inducible urticarias, let's say cold urticaria, someone jumping into a freezing cold pool can do a lot of nasty things in terms of affecting other organ systems, as everything is all connected. So I think it's important to at least ask this, elicit a good review of systems, so to speak, in terms of when the disease is most active, because they could be coming in to see you completely clear. Just as an aside, CSU is one of those invisible dermatoses in some respects. As a patient's very active, they call, they get the appointment 3 to 4 weeks from that point in time. If they're lucky, they come in and it's gone. It's absolutely gone. Like, if you had just seen me last week, you would have seen everything. I was feeling awful. And so that's where, one, good review of systems, good history, but two, in this day and age, ask for selfies. A lot of patients will take pictures on their cell phones and not hide them in some random folder for anyone to look at. You can ask them, do you have any photos? They may forget in the moment, they may forget they've taken photos of past flares. That can be very helpful in terms of evaluating the clinical picture, but certainly you want to ask about these different organ systems that could possibly be involved, as that can certainly insinuate that, especially with inducible urticarias, if that's what they're associated with it, to really avoid certain triggers that could result in very concerning symptoms and even disease. By the numbers, CSU is pretty common. At any given time, up to 1% of the world's population has chronic urticaria, and 2/3 of these have CSU. The rest will have, once again, the inducible urticarias. There's a subset of autoimmune urticaria where the CSU, or actually CU in this case, because it's not spontaneous, the CU is associated with an underlying autoimmune disease, whether it be SLE or something else. That's a little bit rarer. From the data, it looks like women are more commonly impacted than men. And there are now at least some longitudinal prospective studies following patients over time, many retrospective studies looking at time of onset, duration of disease, remission. What are potentially some things that can highlight if someone is going to be stuck with this long term versus maybe burn out, go into remission. So we are starting to develop more of a repertoire when it comes to that information. But I think the end all be all is this is a really common condition and it lasts. If someone has this for longer than a year, the likelihood it's going to continue onward, about 50% of those folks will continue to have active disease 5-10 years down the road. One other thing I think that kind of sticks out in the literature is more resistant disease to treatments. The need to dose escalate antihistamines, which we'll get into, also portends a worse prognosis. While on average, the disease can last for a couple years, there's a very good subset that will have this for decades. And there's no predictor, there's no biomarker currently that will insinuate whether someone will have this for a year, 2 years, or lifelong. So what is the workup? I think I'll start towards the end, which is really try to limit the $1 million workup. Do everything in your power not to harness your inner house MD, because what's been shown is that often these patients will get 1 million blood tests, biopsies, you name it, and either A, you find a whole lot of nothing but spend a lot of money, or B, you find incidentalomas. And the reality is, and this is evidence-based, that a full-on workup, unless there's something in the history suggestive of an underlying condition that would really be an instigator to do a workup, a full-blown workup is not necessary. Really, your focus should be on ensuring you have the right diagnosis, doing the inducible testing at the bedside, depending on what guidelines you're looking at. Some do recommend some simple testing, some non-specific markers of inflammation like ESR and CRP. I honestly don't really get that because they're not specific to CSU. So if you have high CRP, is that related to CSU? Is it related to increased cardiovascular risk factors? But I think the general consensus is keep it narrow, keep it purposeful. Do not work up everything under the sun when you're facing these patients. Now, I mentioned this before. The differential diagnosis of urticaria can be quite broad. I tried to order this list based on frequency. We see things. So at the very top, papular urticaria, insect bites, arthropod assault. I love that name. And I love alliteration, so it works out nicely. Certainly, they can look urticarial, but they'll be persistent. They'll last longer than 24 hours. Other things in the vascular reaction pattern, erythema multiforme, gyrate erythemas, EAC, for example. Erythema chronica migrans can look urticarial. However, they are persistent. Bullous pemphigoid can be urticarial on its own, or it can have an urticarial phase before you get those beautiful subepidermal blisters, those tense vesicles and bulla. But once again, it'll be persistent. Urticarial vasculitis is relatively rare, but it's something that always comes up in your differential for urticaria in that it will look just like urticaria. More often than not, you will not see purpura. You will not see something that's non-blanchable. Occasionally you do, but usually it just looks like plain old urticaria, but the details are what distinguish in that the individual plaques will last longer than 24 hours. I personally, in my own experience, find that these plaques tend to burn a bit more, a burning sensation a bit more than urticaria, but just my own experience. Collagen vascular diseases, so the spectrum of cutaneous lupus, probably more in the kind of tumid lupus perspective, acute lupus, but once again, they will be persistent. Morbilliform drug eruptions can certainly mirror urticaria, but timing, progression is all very important. The multiple P's of this lovely pregnancy dermatosis, once again, the urticarial plaques and papules have a kind of unique presentation in terms of where they start and expand from, periumbilically, but also they will persist, each individual lesion, longer than 24 hours. And the list kind of goes down in terms of less common things. You can even think about, adult onset Still's disease, mast cell activation syndrome, which is extraordinarily rare. I just randomly have a couple patients with it. But I think what really sets these all apart, even though depending on which disease, the morphology can mirror urticaria, it all comes down to timing. Now, some things to think about when it comes to external things that can influence or exacerbate or instigate disease, and things that maybe, I mentioned before, be very purposeful. Think about why would you order a certain test? There certainly can be things in the history or at the bedside that may suggest sending to allergy immunology for food studies. Maybe there's drug intolerance. I know we haven't talked about pathophys yet, but in thinking about not just immunologic pathways leading to urticaria, there are non-immunologic pathways, direct mast cell degranulators, and there are many of them, notably in children. NSAIDs are a common one. So in terms of, is there some external factor causing this due to immunologic or non-immunologic causes, something to certainly think about and pursue. We know that stress can be an independent risk factor for longer, more recalcitrant disease. There was actually a really nice study looking at patients with CSU and looking at depression and anger as independent risk factors for more recalcitrant and persistent disease. And they found that, yes, these absolutely contribute. Just aside from that, something interesting was that the majority of individuals in the cohort were women, and they were all married. Just throwing that out there. But I think, all joking aside, it's important to recognize the impact of one's emotional state on the recalcitrance and perpetuation of disease. Infections, we know for acute urticaria, remember I said food, drug, or bug. So infection can certainly be a driver of acute urticaria, but chronic latent infections can also be problematic. H. pylori has come up in the literature multiple times. Once again, use your questions to guide proper workup. I mentioned also before about autoimmune disease and autoimmune-associated chronic urticaria. So in your review of systems, if something certainly pops with respect to being suggestive for maybe autoimmune thyroiditis, and depending where you're catching the patient, they may be up, they may be down. So I think certainly let the questioning and the exam guide that workup. Discuss mental disorders a little bit. And then, as I mentioned before, you're allowed to have more than one flavor of chronic urticaria. Patients with CSU often have inducible urticarias. So get out your elongated applicator, get an ice cube, tell your patient to do some jumping jacks, and use the tools before us that are very simple to elicit some of these inducible urticarias. But ask questions first. You don't need to jump into the testing. I always ask my patients who I'm considering CSU, I'll ask them the litany of questions that relate to each of the forms of inducible urticaria. And this slide is to highlight a really nice algorithm to work through how you break apart the different flavors of both chronic urticaria, but also angioedema. And you see there is this nice Venn diagram-esque element to it with respect to the overlap, because you can have patients who have both. Angioedema alone is a totally different bag of worms. We're not going to address that. But when you're thinking about urticaria, and I like this component of it, first asking about kind of what we talked about earlier in this portion of the lecture about joint pain, fever, constitutional symptoms. Because if they have hives plus urticaria plus, then we might be starting to think about some of the autoinflammatory disorders, maybe some of the kind of weird familial Mediterranean fevers, muckle wells, things that have urticaria and other things going on too, not true chronic urticaria. So I like that that's early on to help delineate from then, okay, none of that, but the wheals last for less than 24 hours. Okay, we're thinking about urticaria. Greater than 24 hours, maybe we're thinking about vasculitis. Maybe we're thinking about Bullous Pemphigoid, or that list of differential diagnoses. So I really like how this is structured. Very quick, simple questions to get you on the right track. And then, of course, going down this list, thinking about doing some of the inducible testing, following appropriate questions. And then if you're going to mix in angioedema, it's always important to check MedList. As we know, ACE inhibitors can induce angioedema at any point. It could be 9-10 years later of being on one of the pills, so to speak, and it can develop. So I think it's always important to check that. Okay, let's shift gears and start talking about the therapeutic approach in the thinking of going through the diagnostic criteria, making the right diagnosis. Now, what are we going to do about it? So what I really like about the kind of 3 steps proposed in this 2022 paper is, first and foremost, we're treating till it's gone. It's not about getting it 75% better, getting it 90% better. You treat and you do whatever you got to do until it is gone. And it is gone for a while. And that's where we don't have kind of consensus on in terms of for how long. And then you start to pull away to get the minimal amount of medication for the maximal impact. Yes, certainly search for things that could be instigating disease, the inducible stimuli, so to speak, drugs, chronic infection. That's where your discussion is going to come in. I'm not going to belabor this point. And your pharmacologic intervention are going to be purposeful. Starting off, they're going to be targeting the problem here. Histamine number 1. But if you think about and we look at the different therapeutic guidelines in the US, in Europe, many of the things aren't on label. We only have a handful of on-label drugs. We talk about on-label in the US in terms of FDA-approved medications. But I think the key thing is we are going to ramp up, we're going to race up that ladder, that staircase, so to speak, to get to that one and done, getting that gone. And then once we get it clear, we're going to pull back. And I like number 3. I really like it a lot. As much as needed and as little as possible. That one sentence captures pretty much everything I've been saying on this slide. Really, you want to get it gone, use as much as you need, and then pull it away for as little as possible to maintain that 100% clearance. So how do we assess this? How do we assess disease activity? And ultimately, how do we assess disease control? Now, I honestly do not expect any of you to do USA 7s in your practice. That would really slow you down. That might get some patients walking out waiting for you. They're definitely harder ones, but it's a rather onerous scale where you're counting number of wheals, you're assessing itch severity, and then you are kind of checking that throughout the week. So this is a 7-day assessment, evaluating the number of wheals and the quality of that itch. This is a great research tool, maybe not so pragmatic in the real world, but you gotta know it. And the reason for this is when we start seeing new advanced therapies coming out, at least in the US, I can speak to this, that you're going to need to be able to document these validated research tools to speak a common language with payers so they know that patients for whom you want to prescribe these new therapies meet the appropriate criteria to be on said therapy. And then ultimately using this information and using this tool to document progress over time. This is a bit easier. The UCT is 4 questions. That's it. Really simple. You can have your staff run through these. If you have an EMR that allows you to send this out in advance or someone could fill out in the waiting room, all the better. And so here, a higher score translates to disease control. Lower score not good. So very simple questions that have been validated that can give you a numerical score to follow a patient and also assess their severity from day one. This, I think, is very reasonable in the clinical setting. So let's put this to work. So if we think about, if a patient has a certain numerical score, so let's say a UCT less than 12, not controlled, what are you going to do? You're going to ramp up your second generation antihistamines. And we'll get into these in just a moment. And you're going to do that pretty quickly based on both the US and the EU guidelines. Or you might throw in the next level, which is omalizumab, currently the only FDA-approved biologic for chronic spontaneous urticaria. Now, as they get better, UCT starts to go up, 12 to 15, 16. You're going to continue therapy. Maybe you start to pull things away. Maybe you'll start to lower the amount of their antihistamines because that step up mentality needs to be maintained. You don't dose escalate your antihistamines to only get rid of them and then change to something else. This is layer caking. You're going to ramp up fast and you're going to add on. You're going to lay on until you get them clear, and then you peel the stuff away till you get to a point where you keep them clear, but then have them on as few medications as possible. So here are going to be your best friends, your first-line therapies, your second-generation, theoretically non-sedating antihistamines. And I say that somewhat sarcastically because depending on the person, some of these can be very sedating. In my own personal practice, I find fexofenadine to be the least sedating, but I also find it to be the least efficacious among all of them. On the flip side, levocetirizine I find to be the most effective, but also the most sedating. So the current guidelines suggest they really want you to stick with just one as you dose escalate to up to 4-fold the recommended dosing, which is listed here. I personally don't follow that depending on the patient's sensitivity in terms of sedation associated with these. I might mix and match a little bit. In thinking about, the H1 antihistamines overall, these are really the cornerstone of our management. These are going to be your first line. Chances are patients are already on at least one or two of these a day when they come to see you. Maybe not, but I find because they're accessible over the counter that they're taking at least one and they'll say, doesn't work at all. Well, that's because they haven't been optimized. So it's really important that if you're going to start thinking about the next step, whether it be omalizumab or the plethora of off-label therapies, which include other biologics, which include immunosuppressants, immunomodulators, and I'll talk a little about them in the next section, you first want to prove that you can't get them under control with these simple, often over-the-counter options. So you want to ramp up. But the nice thing about, I think, antihistamines is that they're going to work quickly. It's not like typical biologics where you might have to wait 16 weeks to really say, yep, this works or it doesn't. You're going to know within that first month from the point you see them that this is going to work or it's not if you updose to that 4-fold recommended dosing. Now, when it comes to first generation, they're short-lived, they're very sedating. It is not recommended to use them because of those two factors. So we really do recommend the second generation, quote unquote, non-sedating antihistamines as your first line. Now, with our current guidelines, which really only kind of started to touch upon them at the very tip of the iceberg, because at the very top, it's going to be that dose escalation. If you look at the US versus EU or the European guidelines, which is a constellation of a couple different societies. In Europe, the dose escalation happens much faster, where in the US, it's a little slower. But at the end of the day, it's still within a matter of weeks, not months. So I like the stepwise approach. I like the fast ramp up because we got to get these patients clear yesterday. It prioritizes not only the efficacy, but the safety. And we have a lot of data on the safety of antihistamines, not just in adults, but in children, pediatric population, even in the setting of pregnancy with some of these. So certainly a lot of helpful information when getting patients on these. The limitations are, and I think we talked about this before, lab monitoring, or even labs from the get-go. As I said, hey, don't waste your time. Don't waste money on this $1 million workup. The truth is we don't have a consensus or good data either way to say we should, maybe more we shouldn't. But in general, we need more work in this area. But I think at the end of the day, it really comes down to lack of rigorous studies with respect to our therapeutic armament. We have antihistamines. We have omalizumab. That's about it. We have small studies. We have studies looking at cyclosporin, which probably has the most evidence as a third tier therapy. Actually, if you look at the European guidance, cyclosporin, it's actually up there. It's kind of right next to omalizumab, just below it. But in the literature, certainly you can find studies looking at methotrexate, even cyclosporin, as I mentioned, mycophenolate mofetil, sulfasalazine, even narrowband UVB has been studied. However, these are small studies. They're not as rigorous as an FDA clinical trial program. So certainly more is definitely needed in this case. And very often we're left to our own curiosity, to our own ingenuity and creativeness when it comes to coming up with algorithms that we feel work. Very trial and error, if you want my opinion. Granted, I think we need to be creative and certainly aggressive in getting these patients clear, but it's always nice to have some data in your back pocket. And to date, that data is somewhat limited. Now, with all that said, so we can play with a bunch of off-label toys, but first and foremost, we're going to use what's on label. But even when we do that, when we max out the antihistamines, even when we use omalizumab, there's still a good number of patients who are not well controlled. Just looking at antihistamines alone, about 50% of patients who are updosed, who are maxed out on antihistamines, still have active disease. Omalizumab, the numbers are lower, but still there, as high as 30% of patients in some studies are still not controlled on the only FDA-approved drug for CSU. So clearly, there is opportunity here. There's a need for additional therapies that really take the underpinnings of disease into account. That's a lovely segue to our targeted therapies for the management of CSU. Now, I like the title of the slide because it says theories, because that's really what they are. You know, if we look back and think of the described pathophysiology of CSU, it's really the end of the story, right? We focus on the mast cell which could do quite a lot. The mast cell that really shouldn't be in tissue, at least in our skin, so to speak. The mast cell that has preformed mediators and can also produce, on a moment's notice, a whole bunch of pro-inflammatory and vasoactive factors. You know, pretty impressive factory, if you don't mind me saying. However, we still don't really understand why this all happens. I mean, there's the autoimmune theory, and certainly that's reasonable given there's a subset of chronic urticaria patients that also get urticaria that have what for all intents and purposes is chronic spontaneous urticaria, but it's affiliated with that autoimmune disease. And one would assume that if they have SLE, RA, so lupus, rheumatoid arthritis, that there would be serological markers for the activity of that disease. There have been other proposed underlying pathophysiologies related to cellular defects, certain factors in plasma, maybe a chronic indolent infection, chronic exposure to, foods or additives. The end-all be-alls we don't know, but we're getting closer. I've been lecturing on CSU for many years, and what is amazing to me is that our understanding and what I actually even talk about when it comes to the pathophysiology has expanded tremendously just in the last couple of years. And it's not just a laser focus on the mast cell. So let's think about the pathophysiology from the perspective of the therapeutic kind of pipeline. So right in the middle here in this nice illustration of the skin, on the top is the epidermis. Those are those keratinocytes, so kind of pinkish cuboidal cells. But we're really talking about the dermis. This is a dermal inflammatory process. The mast cell absolutely is right in the middle. Now, historically, we thought about the IgE cross-linking of high-affinity Fc epsilon receptors that in turn will cause mast cells to vomit out all their internal contents, histamine being a key one in there that then will hit its histamine receptor, cause vasodilation, it'll sensitize sensory neurons, send a signal to the brain, all that fun stuff. Now, just the mast cell alone offers unique opportunities beyond IgE binding, beyond histamine, because we can't forget there's IL-4 receptors, there are opiate receptors, there are complement receptors. There's a whole bunch of different things on that cell surface that we largely ignored, at least in the general kind of audience, for so long. And there are even things inside the cell that play a big role in terms of getting to that over-the-toilet vomiting stage that these mast cells enter once things are set in motion. That could potentially be targets for new therapies. But outside the mast cell, there are other cells that we can blame. B cells, well, where's the Ig come from in the first place? B cells. We know that polarized T cells, Th2 cells play a role. Remember, these are cells that make IL-4 and 13. We know eosinophils can play a role. Whether it be that we're thinking about the cytokines themselves or receptors, the receptacles for cytokines, lots of opportunity. And what's so exciting to me is all these red boxes. For so long, chronic urticaria was an orphan disease from a development perspective. There just really was not a lot of interest. But look at all these therapies. Obviously, omalizumab is already approved, but we have a lot of new therapies out there being explored. We'll talk about some of them. I mentioned before that we don't have great biomarkers. We don't have great labs to highlight the severe disease or be able to follow disease over time, or even predict who may respond to one therapy versus another, or will the disease burn out on its own. I mentioned CRP before, which yes, high levels indicate systemic inflammation, but it's not specific. Certainly, if we think this is associated with autoimmune thyroiditis, yeah, anti-TPO, maybe ANA, certainly can be helpful. But as of right now, there's no one biomarker that will predict whether someone will have disease lifelong or whether they'll respond to a therapy better than another. In fact, even when we think about IgE, for omalizumab, we used to do pre-treatment IgE levels. Now it's not even necessary in terms of dosing. So I think a lot of work is needed here to really understand if we do have serological markers that can help us in our diagnosis and management of these patients. So I started to get into the algorithm before, and this just highlights the point of running, not walking up the stairs. So you start off with standard dose. As I said, I think patients will probably already be on at least the standard dose or maybe double that, but you could go up to 4-fold the recommended dosing, and I recommend doing that quickly. By 30 days after that visit, if that patient has not been controlled, they should be at 4 times that recommended dose, unless contraindicated or they're getting side effects. And if they're not doing well with that, guess what? We're going to step number 2, which is going to be omalizumab on top of that 4-fold dosing of antihistamines. Maybe, depending on the patient, some off-label therapies I mentioned before. Cyclosporin, which personally I like because it works very fast, very, very quickly. The problem is lots of side effects, and you also can't keep them on it forever. And the studies that are out there show that as soon as you take them off, the problem comes back. Also pretty burdensome when it comes to lab monitoring, unfortunately. But you can think about even some of the immunomodulators like dapsone, hydroxychloroquine, certainly can be used and has been studied in this setting. There's also some evidence for adding on high-dose vitamin D, for example. So a lot of off-label things to play with. However, limited data support their use. So we're going to stick to the book, so to speak. Next step will be omalizumab. And if that doesn't cut it, then yeah, you're really going to rely on those third lines, which include, once again, cyclosporin, methotrexate, mycophenolate mofetil, sulfasalazine, hydroxychloroquine, dapsone, even colchicine. Both dapsone and colchicine are anti-neutrophilic, and that's how we think that they work in chronic urticaria, and even narrowband UVB if a patient is amenable to it. You saw this slide before. I'm not going to belabor it, but I do like this tool because it is a quantitative way of tracking someone's treatment journey, which makes it ultimately easier to argue to insurances why someone might need an advanced therapy, even if it's off-label. I also want to highlight, yes, ramp up real fast, but then you pull away when possible to make it simpler for the patient, all along the while making sure they stay above that threshold from a numerical, completely controlled status. Now, this is the money slide. Look at all of these therapies. Some are already commercially available for the management of other inflammatory diseases. Some of them new to the scene, but a lot of excitement and a lot of energy being put into developing and expanding our armament to manage CSU patients, especially that subset who are just not responding to the things that we have. Omalizumab, as I mentioned, already out there. Dupilumab already has multiple indications in the dermatology space. Not currently approved for CSU, though that pathway has been established and there is work ongoing. But then we also have some novel targets like going after Bruton tyrosine kinase with remibrutinib, and there are other BTK inhibitors as well. Other targets, whether it be cytokine or receptor targets. So certainly exciting time for chronic urticaria. So let's maybe quickly go through some of the data, because honestly, I find that clinical trial data, FDA clinical trials, they serve a purpose, which is to get into our hands. It doesn't necessarily mirror the real world. And this is a great example of that. Look at the two identical, for the most part, identical phase 3 studies, Asteria 1 and 2. The whole point of having two identical studies, though in this case, I will give some credit in the formulation of the study in that patients were allowed to still be on antihistamines, where very often these are monotherapy studies. But here, we're seeing semi-real world conditions, being on antihistamines plus omalizumab, a line in the sand in terms of evaluation to see what % of patients met the primary outcome as defined by the FDA. Now, the glacial study, we're seeing a lot more of this. This is more of a real world study. So patients could be on up to 4 times the approved dose of H1 antihistamines. They could be on leukotriene antagonists, which we didn't really talk about, which are within at least the US guidelines as something that could be an add-on. H2 inhibitors also have been, in the mix, but every couple of years, both actually the leukotriene receptor antagonists and H2 blockers, they tend to fall out of favor, come back into favor. So it kind of goes back and forth. And so a combination of H1, H2, and leukotriene antagonists has definitely been out there in the literature and has been utilized. But that's what I like about this is the glacial study, patients could do any one of these or all 3 plus omalizumab, and it was 1 dose. Now, actually, the standard dose that we use in that label extension we saw in the last couple years. And this was overall a substantial time period, giving us a lot of information with respect to how this drug works. So certainly when this first came out, really broke the glass ceiling with respect to a lack of innovation in this space, and certainly has made a dent in our ability to manage this disease. So a dose-dependent component, looking at the 150 versus 300, clearly 300 milligrams has a more profound effect on the UAS-7 score. So remember, it's that score for a full week, number of wheals, and the quality of the itch. So a higher % of patients had a UAS-7 of 0. So 40% in the kind of more classic phase 3, but in that longer term study, 33% of patients had absolutely no activity in that 7-day window. So certainly something to consider. And that's why it's so important to understand what these tools mean, so you actually can interpret the data with a clinical and pragmatic lens. Now, some of the things that are up and coming, dupilumab, probably in, we can see kind of a light at the end of the tunnel, potentially in terms of getting this indicated for CSU, though time will certainly tell. The study design was adolescents and adults because we have to consider, all age ranges. So in this case, it's really nice that this isn't just 18 and up. Patients who are refractory to H1 antihistamines. There were kind of some unique designs here in terms of patients who had never been on omalizumab or those who were incomplete responders. So kind of study A and B. And I think that's important because we know outside of the CSU world, patients who have been exposed to other biologics, and I think psoriasis is a great example of this, that when patients sometimes are exposed to other biologics, they don't respond the same way as compared to a naive patient. And therefore, we see very often that call out in the papers and the publication and the slide decks that there may or may not be any difference between biologic naive or experienced patients. Okay, what are the endpoints? The primary outcome, what the FDA cares about, itch severity score, IA7 at the end of the study period. A lot of secondary outcomes, which are more for us, the UAS7, hive severity score, the UCT, lots of assessments to give us a better understanding of how we'll behave in our hands. So small study kind of speaks to probably the need for new therapies, in terms of powering the study and how many patients you would need to study. Reduction in itch severity, there was 63% reduction with the dupilumab arm versus 35% in standard of care with antihistamines. So certainly a significant reduction, 10.2-point reduction with dupilumab and a 6-point reduction of standard of care. So there definitely was a significant difference between the two arms. In terms of urticaria activity severity, kind of similar numbers, 65 versus 37% in the two different arms, 20.53-point reduction with dupilumab versus 12-point, and this was statistically significant. The treatment emergent adverse events were very similar. And I think one of the nice things with a drug that already has multiple indications is we know what we're getting. We know a lot about the safety given all of the parallel indications. And I think we could say probably the same of some of the other therapies being explored for CSU that are already out there. It gives us a little more confidence that's being used in the real world. Looking at the results from study B, so this was a smaller subset, 83 patients, 24-week period, which seems like a pretty long time for a biologic study. Dupilumab placebo every 2 weeks, and also standard care of antihistamines. Now here, the issue was it did not reach statistical significance in interim analysis, even though patients were doing better. And this is probably one of the reasons why we recently saw the headline, the FDA asking for more information and pushing out the decision on whether it's approved or not, probably at least another year or so, if not longer. So it's important to, understand why these things happen. How do we define failure in a FDA, kind of perspective? But this certainly is delayed. And so we'll see what happens over time. So there are other ongoing studies for dupilumab and CSU. So we have study C, estimated to be completed sometime 2024. So this kind of came about after that decision. And the hope would be to kind of recover following that study B to look at specific patients. And, I think it really is important to look at those omalizumab resistant or omalizumab inappropriate patients, because we definitely need more options besides just one kind of targeted therapy when it comes to the management of CSU. And then we do have a study upcoming looking below the 12 years of age range, which I think is very important. There definitely are a lot of kids who develop CSU. There are some nice studies looking at the impact on development, quality of life, and persistence into adulthood. Some other studies here, we have an IL-5 receptor cytolytic monoclonal antibody, so kind of a unique molecule. This is looking at a 24-week single-center, single-blinded repeat measure study in CSU in those unresponsive to our first-line therapy, second-generation H1 antihistamines. Phase 2 trial underway, so we got some time. But as you can see from this one figure, certainly a signal over study visits, so something to keep an eye on, but definitely too early to tell. Phase 2 really is meant for kind of identifying what's the right dose to then use at a larger scale in the phase 3 to hopefully make the data generalizable. So TBD, but certainly something to keep an eye out for. Here we got another one. I think this is kind of an interesting target, and some of you may recognize thymic stromal lymphopoietin from the atopic dermatitis world. And here, there could be an opportunity. There is an Inception study that is currently, I believe it's still recruiting, but looking at this TSLP targeting monoclonal antibody to undermine the burden of CSU. So certainly a unique target that has not been looked at before, but I think we're way too early to say one way or another. And here we have another monoclonal antibody looking at antihistamine, refractory CU, proof of concept. Certainly, the data is kind of all over the map here. We have some of the summary data here, the USA7 data. I think we're a little too early to tell, but I think certainly it is promising across the 3 forms of antihistamine refractory CU. So I'm certainly excited to see what's going to come next. This data can be found. It was published in 2022. So certainly looking forward to hearing more about this molecule. Then, we have this top-line data on barzolvolimab. Here, looking at phase 2, top-line data, week 12, looking at, once again, as I mentioned, phase 2 is looking at dose escalations. So what doses might have, a clear signal, which one should we go with, or can we stay at a certain dose and don't require higher doses? But you can see, once you start to get to the 150 milligrams Q4 weeks, very similar data to the 300. So I'm very curious to see, what dose, but my assumption is we're going to see the 150 coming down the pike, especially given the USA7 complete clinical control scores with the 150 every 4 weeks. So to wrap up, that's a lot to digest, but I hope you walk away with some key points. CSU is common. It is commonly underdiagnosed. It is commonly underestimated. It has been commonly forsaken from a therapeutic pipeline perspective until recently. But times are changing, and it's a very exciting time when it comes to the management of CSU. And I think that's part of maybe why all those fill in the blanks are so easy to say, because when you don't have a lot of things to play with that are FDA approved, you may shy away from managing a disease. But when you're armed and capable of managing a condition with FDA approved therapies, that's certainly a game changer. So remember to ask the right questions. Remember the key diagnostic elements when it comes to this disease: single lesions not lasting longer than 24 hours, a burning itch, not an itch that necessarily feels good to scratch. Knowing the definition of less than 6 weeks for acute, greater than 6 weeks altogether for chronic, and different flavors of chronic urticaria. Less is more with laboratory workup, and climb that therapeutic ladder like you're being chased by a pack of wolves. Climb it fast, get these patients clear, keep them clear, and then pull away to have the kind of minimal therapeutic composite with the maximal benefit. And as we see more therapies coming down the pipeline, whether they be successful or failures, it doesn't matter in my opinion, because it teaches us something about the underpinnings of disease for which we don't have a lot of information. We're learning a lot, but we need to understand the pathophysiology before we can really get full control over a disease. Well, that ends our discussion for today. I hope you found the activity informative and useful to your practice, and I encourage you to participate in the other modules that are part of this curriculum. Thank you so much for participating.
Hello, this is Dr. Dede Morel from the University of New South Wales in Sydney, Australia. Welcome to this education activity on Bullous Pemphigoid. This activity is part of a 4-part curriculum entitled Evolving Concepts in the Pathogenesis of Inflammatory Dermatologic Disorders and the Rationale for Targeted Biologic Therapy, focused on moderate to severe atopic dermatitis, Prurigo nodularis, chronic urticaria, and bullous pemphigoid. You can access the full curriculum at PeerView. Today's presentation is on improving the diagnosis and understanding burden of disease in patients with bullous pemphigoid. Bullous pemphigoid, or BP for short, is the most common autoimmune subepidermal blistering disease and represents 80% of subepidermal immunobullous cases. It has a reported incidence of 10 cases per million per year. BP most commonly affects elderly patients between the ages of 60 to 80, with a rising incidence exponentially after the age of 70. In fact, patients over 90 years of age have a 300-fold higher risk relative to those under 60 years of age. Although described as a rare condition, bullous pemphigoid has been growing in prevalence over the past 2 decades, underscoring the need for healthcare providers to be aware of it and well-equipped to care for these patients. What about the definition for pemphigoid? The term bullous pemphigoid is in fact the late stage of the disease, and if we stick with that definition, we will miss patients at earlier stages of the disease. BP starts with itch or pruritus, and then after sometimes many months, a rash develops, which can mimic eczema. But the final stage in the phenotype of the disease is the development of blisters on an erythematous base. The disease may present with localized disease, for example, just involving the feet or the lower legs or the hands. And here in these photographs, you see some examples of the urticarial bullous pemphigoid lesions with the erosions and blisters studied within them, a patient who had the severe blistering phenotype on the feet, and over to the right, a patient with more the urticarial plaques with no blisters yet developing. In this disease, the blistering is occurring at the basement membrane zone, and hence, because the intact epidermis is above these blisters, they form these tense bullae with the liquid trapped inside. And you can see enough urticaria develops with accumulation of inflammation and liquid leaking into the skin, and you see there these tense blisters, which occur most often on the flexural areas. For some reason we don't yet understand, the feet and the hands are predilected in bullous pemphigoid compared with more superficial blistering diseases such as pemphigus, which favor more the face and scalp. And this could be confused with dyshydrotic eczema when patients present just with the blisters on their hands and feet. BP is often confused with the diagnosis of hives or urticaria, but if you see this for the first time in an elderly patient, then you should consider that this could be BP. After some time, these red areas begin to blister, and then this is the time when the penny drops and a doctor may start to think about bullous pemphigoid, but it's much harder to get the disease under control if it's not diagnosed until this later stage. So what are the challenges in recognizing BP? Because all patients have huge delays in diagnosis. Over 20% of patients with BP are presenting with a non-bullous form of pemphigoid by the time they're seen by an expert dermatologist. And of these patients, about 10% develop blisters at a later stage. So therefore, BP should be considered in elderly patients who have itching, and practitioners need to have a higher index of suspicion. The other problem is that BP is often misdiagnosed for other conditions, including atopic dermatitis, systemic allergies, and urticaria. The known risk factors for BP, besides age of the patient, include genetics and certain medications, in particular certain blood pressure medications, diabetes medications, and especially the gliptins, and also immune checkpoint inhibitors. Two other main factors contribute to the increasing BP prevalence worldwide. These are the growing elderly population with longer surviving people who have multiple comorbidities, and the increasing exposure of the elderly population to drugs that could potentially trigger bullous pemphigoid. A strong association has also been found in case control studies between BP and a number of conditions. These are mostly neurological or cardiovascular. The neurological associations, which have been found in multiple studies, include some type of destruction of brain tissue, which could cause dementia, Parkinson's disease, Alzheimer's disease, stroke, schizophrenia, epilepsy, and also multiple sclerosis. Cardiovascular diseases that increase risk factors include hypertension, stroke, venous thromboembolism, and pulmonary embolism. Less common associations that are seen include sometimes the association of psoriasis, and whether or not neoplasms are really associated with bullous pemphigoid is somewhat controversial because as you get older, the risk of cancer obviously increases. When BP is associated with multiple comorbidities in elderly patients, the mortality from this disease at 1 year has been as high as 23%. What about quality of life for patients with blistering disease, bullous pemphigoid? Well, obviously, this contributes to a reduced quality of life and increased psychological burden, in particular anxiety and depression. And here we see shown a couple of case control studies. In this one by Chorus et al. From 2016, the patients were assessed using the Validated Hospital Anxiety Depression Scale, or HADS, the DLQI, or which we all know about, the Dermatology Life Quality Index, and a loneliness scale. And you found that the mean DLQI score was about 9 out of 30, which is a moderately high score. The HADS score gave a statistically significant difference for depression subscale, but no difference in anxiety subscale. And this loneliness scale gave higher scores in the BP group. In the second study published in 2020 by Briand et al., they used the Itch-Equal and the 5D itch scale and found that these scores were high. Mean Itch-Equal score was 56 over 110 and 5D itch scale was 16.5 over 25. And these and other studies highlight the reduced quality of life in these patients. Not mentioned here is a disease-specific autoimmune bullous disease quality of life measure as well, which our group validated and has been revalidated in multiple languages and cultures, and that has been used in a number of studies, specifically looking at quality of life in BP. Not mentioned here is a disease-specific autoimmune bullous disease quality of life measure as well, which our group validated and has been revalidated in multiple languages and cultures, and that has been used in a number of studies, specifically looking at quality of life in BP. Now, for diagnosis, the biopsy is the gold standard for the diagnosis of BP. It requires 2 biopsies. Both are lesional and perilesional. So you take the standard biopsy for lesional in the edge of the blister, incorporating the intact skin and part of the blister. Otherwise, the roof of the blister floats off in the jar and leaves you only with the bottom of the blister, which doesn't allow the pathologist to tell you the level. On the other hand, the essential perilesional direct immunofluorescence biopsy should be taken in intact skin, and that should be about 1 centimeter away from a blistering lesion. If, however, your patient has no blisters and you're biopsying them earlier in the disease without any blisters, then you can take both of these biopsies as separate biopsies within the urticarial plaques. If the patient is just itchy and you want to do these tests, you can just choose a flexural area of the skin where they're itchy, such as the thigh, and even then the DIF is positive. There may be inflammation, even though you don't see anything visible in the skin. Also, blood tests are required. Serology or a specific ELISA test is the best, or if you don't have access to that, indirect immunofluorescence test. These tests are to look and see if the patient has autoantibodies in the hemidesmosome area of the skin. So it should be in the roof of a blister in the disease, or if you have salt split skin access in your laboratory, it should stay in the top of that blister. With the ELISA test, you're looking for specific antibodies against the two pathogenic proteins in the hemidesmosome, the BP180 protein or the BP230 protein. And some patients have both, but most patients just have BP180 positive. In a study from the Mayo Clinic, about 7.5% of healthy individuals had autoantibodies against these proteins. And that is why you cannot rely just on a blood test, because you can have antibodies to irrelevant parts of these proteins which don't lead to the disease. And this is why the skin biopsies are essential, as well as the blood tests. When you do these tests, as I said, if the blister is present, you try to get the edge of that blister in your biopsy so that in this example, you can see the blister under the epidermis, but you can see to the side that the epidermis can still attach to the dermis. So you can see the full thickness through this blister. In addition to a subepidermal blister, you will see lots of inflammation, in particular in BP, eosinophils are present. And in the ones without blistering, you will see the eosinophils, and it can be harder to distinguish such a biopsy from other causes such as insect bite reaction. This is why the direct immunofluorescence test is crucial, because in insect bite reactions and ordinary eczema, you will not find the immunofluorescence with an antibody that's looking for IgG or complement 3 deposition at the basement membrane zone, indicating that it is Bullous pemphigoid. Now, because this isn't a salt split specimen, if you're very astute about blistering diseases, you realize that other subepidermal blistering diseases can also look like this, including epidermolysis bullosa acquisita and bullous lupus. And that's why having the ELISA test is important, because that will show you it was specifically BP antigen and not collagen 7 as the antigen. This little schema here shows you the difference in the pathological findings of Bullous pemphigoid versus the other autoimmune blistering diseases. For example, on the left, Pemphigus vulgaris will split the skin above the basal layer of keratinocytes. Second one is Pemphigus foliaceus, where the skin splits in the granular layer of the epidermis. And then you have normal skin over to the right. And here with Bullous pemphigoid, you have the subepidermal blistering, the most common diagnosis being Bullous pemphigoid. But if it's IgA antibodies, it's a different disease called linear IgA bullous dermatosis. Much less commonly, patients can develop autoantibodies against other proteins that are deeper in the basement membrane zone, such as collagen 7 that makes up anchoring fibrils. And that is a disease called epidermolysis bullosa acquisita because it mimics the genetic disease EB, bullous lupus, because lupus patients can develop autoantibodies against collagen 7, and a completely different phenotype of disease called dermatitis herpetiformis, which doesn't really give you big tense blisters, but lots of inflammation in this area of the skin. And all of these autoimmune diseases have different autoantigens, but bullous pemphigoid is by far the commonest. Now, it's important, therefore, to be sure of the diagnosis before you proceed with the treatment, because these other diseases are more resistant to standard treatment and require different paradigms of treatment. And so that's why often there's delays in diagnosis, and these more complex cases often go out for second opinions. If somebody sends a case of possible bullous pemphigoid to you, claiming that that's what the patient has, you can't just accept someone's word for that. You need to get hold of the original diagnostic data, chase the biopsy reports, the ELISA reports, and ideally have access to some clinical photographs, because the patient may already have had lots of treatments and the clinical appearance will look different. And you may, in fact, have to repeat some of these tests. It's important to score the disease severity of bullous pemphigoid, and our team internationally has developed and validated a score for that called the Bullous Pemphigoid Disease Area Index, or BPDAI. And as I mentioned, these quality of life instruments specific for autoimmune blistering diseases, AVQOL for the impact of the disease, and TABQOL for the impact of the treatment that you're going to put the patient on, which has its own quality of life issues. Ideally, we follow our patients with ELISA testing for the activity of the antibody against the pathogenic proteins BP180 and BP230, as we see if the patients are responding to treatments and if they're going to relapse. Over to the right, you see a couple of other diseases that could be mistaken for bullous pemphigoid, including a child with EBA and a woman with mucous membrane pemphigoid. This is the BPDAI score. It's used in all the clinical trials of bullous pemphigoid as a validated tool, which is accurate between different doctors scoring the patient, so long as they've been trained how to evaluate it. It has 12 common sites of involvement of bullous pemphigoid, and then each site receives a score up to 10 for the degree of blistering in this left-hand column, and for the degree of urticaria or erythema in the middle column. And don't forget that brown areas or areas of scarring and damage are not indicative of current disease activity. So that's why over to the right, you score yes or no for that, so you don't confuse it with disease activity that is part of the responsive to treatment element. If the patient with BP also has mucosal involvement, which may occur, it needs to be scored separately in each of these 12 areas of mucosa. And this has been shown to be not only valid, responsive to change, reliable between different doctors, but makes the results of the studies and treatment interpretable. In addition to that, a pruritus score has been developed for bullous pemphigoid with 3 questions, which are completed by the patient. But if the patient has dementia or cannot respond, rather than having a relative answer the questions who can't feel how itchy they are, you have to infer it by how many scratches or excoriations they have. Each of these is scored out of 30. The first questionnaire one is how severe has your itch been over the last 24 hours, out of 10 over the past week and over the past months. Now we're going to turn to the modern therapeutic approach for the management of bullous pemphigoid. The treatment goals for BP are to improve the patient's quality of life and to induce, ideally, medication-free remission, and if that's not possible, medication-managed remission of the disease. The most common treatment of BP is now going to be explained. The treatment can be divided into several different types of medication. First of all, topical treatment with topical steroids. Secondly, anti-inflammatory antibiotics, including doxycycline and dapsone. Thirdly, immunosuppressive agents, methotrexate, mycophenolate, rituximab, immunomodulatory agents, IVIG, targeted treatment, omalizumab, and dupilumab. Now, missing from this list is the most basic treatment that has been used for many years, which is oral corticosteroids. And these, we realize, are still in use by all of us because patients can't always get under control with safer topical steroids. How do these experts treat localized bullous pemphigoid, ideally without any oral steroids? A survey of 65 bullous disease experts from 27 countries, the majority stated that topical corticosteroids were used, and mainly for an initial dose of 20 grams per day. That's assuming that they were applying it twice a day. And doxycycline was often used along with topical corticosteroids in around 15% of cases. And this was conducted by Professor Pascal Joly and the EADV Task Force of Blistering Diseases. Here we see a therapeutic ladder. If the patient is presenting with early onset or relatively mild and moderate bullous pemphigoid with BPDI scores of less than 20, or BPDI score greater than 20 and less than severe scores of 57. What you'll see here, first choice in localized BP is to apply potent or superpotent topical steroids on the lesions only. And in non-localized but mild to moderate bullous pemphigoid, these superpotent topical steroids should be applied ideally twice a day, at least once a day, but now it needs to be applied on the whole body except for the face, because these autoantibodies are attacking the skin from underneath and may or not yet have caused urticaria and blistering everywhere, but they're coming to the skin from the blood and they're not just where you see them on the surface. In some cases where these topical corticosteroids are very expensive, which is the case where I practice in Australia, where it's prohibitively expensive to buy topical steroids, then patients often have to resort to oral corticosteroids, which can cause more systemic side effects. And the initial dose of those is 0.5 milligram per kilogram per day. Now, a second choice was to try the patient on one of these non-anti-inflammatory antibiotics, doxycycline or dapsone. And in some cases, often in our case, we would use those in preference to giving the patients oral corticosteroids. We might prescribe topical steroids as well as one or other of these. On the other hand, if the patient has severe bullous pemphigoid with a BPDI score greater than 57, the first choice, there are two treatments recommended. Clinical trials published in the New England Journal of Medicine showed definitively that superpotent topical steroids twice a day, or worst case scenario, once a day on the whole body except for the face, were as effective as, but much safer than, oral corticosteroids. In the clinical trials, those were given at a dose of 0.5 milligram per kilogram per day. When both of these treatments are tried, or either one, and the patient does not achieve control of the blistering or the itching or the disease within 3 weeks with a dose of 0.5 milligram per kilogram per day of prednisone, two options may be considered. One is to increase the dose of prednisone to 0.75 milligram per kilo per day, or the other is to add superpotent topical steroids to someone who's still on the 0.5 milligram per kilo per day dose. Now, what can happen is you get the patients under control and then they don't need to necessarily do anything else apart from taper things. But there are several experts who believe that additional corticosteroid-sparing anti-inflammatory agents should be given. And in the randomized controlled trials of these, at least for azathioprine and mycophenolate and cyclophosphamide, no additional benefit was actually proven. There's a small study going on in France of the addition of methotrexate, but it's commonly thought that the patients can be given one or other of these in order to assist the patients in getting off corticosteroids. However, patients who are in poor general condition, which these elderly people often are, or people with contraindications to these medications mentioned, azathioprine, mycophenolate, and methotrexate, then the following options may be considered instead, and they include continuing with doxycycline, using dapsone, or when you can afford it or have it funded, omalizumab, which is an anti-IgE agent, which is involved in the pathogenesis of many cases, bullous pemphigoid. Now, what do you do if your patient is recalcitrant to even 0.75 milligram per kilogram per day of prednisone? Well, in those cases, then yes, you would consider combining the higher dose of prednisone with one of these conventional immunosuppressants, such as methotrexate, azathioprine, or mycophenolate mofetil. However, at this point, other therapeutic options, which have not been validated, may be considered without any particular priority. These include anti-B cell therapies, which are anti-CD20 monoclonal antibodies, one of which is called rituximab, anti-IgE therapy, omalizumab, the one that's anti-IL-4 and IL-13, which is dupilumab, intravenous immunoglobulins, or immunoabsorption. This slide shows you the results of the randomized controlled trial conducted by the French group of oral versus topical corticosteroids in patients with bullous pemphigoid, which was published in the New England Journal of Medicine. The findings for patients with severe bullous pemphigoid were that efficacy was higher using topical potent steroids than systemic steroids, with a significant p-value at 1 year. The 1-year survival rate, however, was much higher in those that were given the potent topical corticosteroid, which was clobetasol, 0.05%, versus systemic steroids, and severe complications were lower in the topical group. The problem with this finding is the practicality of being able to deliver topical corticosteroids twice a day all over the patient's body, because in France, where it was conducted, the hospitalization and nursing to do this is provided for free to the patients. And so this makes this treatment difficult to conduct in some healthcare settings. The topical corticosteroid drawbacks, you can get local side effects such as bruising, skin thinning. The main difficulty is with adherence in putting creams on all over the body, especially in patients who are elderly and who have impaired mobility. Yes, you can get systemic absorption from cutaneous application, but less than you would get from oral delivery. In terms of any chronic corticosteroid delivery, topical or oral, there are many comorbidities caused by the steroids, one of which is osteoporosis and osteopenia. Therefore, bone protection is important in the management of these patients, such as making sure they're taking vitamin D and calcium supplements, doing baseline bone densities, considering giving them prophylactic bisphosphonates to prevent this from happening, monitoring their blood sugar, making sure if they have diabetes that it's well controlled by their physician, telling them to restrict their salt intake and calorie intake if they're taking a lot of steroids because it increases their blood pressure and can increase the risk of diabetes, trying to encourage them to maintain some exercise and to reduce UV exposure. Doxycycline in this study was a non-inferiority randomized control trial designed in England and conducted mainly in the United Kingdom, but also some centers in Germany. These bullous pemphigoid patients were randomized to doxycycline 200 milligrams per day plus topical steroids versus prednisone 0.5 milligram per kilogram per day. And the efficacy at 6 weeks with the doxycycline group was only 74% versus 91% for the corticosteroid group. However, there were far fewer severe adverse events in the doxycycline group, 18%, 36% in the prednisone group. So some people concluded from this study that most patients could get better on doxycycline alone with topicals, and because it was safer than systemic corticosteroids, they prefer to start with this and see if it works and only switch to the corticosteroid oral if it doesn't work. In terms of dapsone, there hasn't been a randomized controlled trial. There have been case series finding efficacy of up to 80%. However, dapsone does have a list of hematological side effects, and blood testing needs to be done every 2 weeks for the first 3 months. It can be idiosyncratic. It can have drug interactions, and a G6PD needs to be normal before it's given. Rituximab, from a retrospective case control study where it was given 500 milligrams weekly for 4 weeks initially, along with steroids, versus corticosteroids only, led to complete remissions 92% in the rituximab group versus 53% in the corticosteroid group, favoring rituximab. In fact, the risk of infection and the 1-year mortality both favored rituximab, but it wasn't statistically significant. A retrospective review of published cases of rituximab over a 13-year period found that more than one cycle was needed for about 40% of the patients to get a complete response, but almost 70% had a complete response with rituximab. In terms of IVIG, it's used for moderate to severe BP patients who cannot tolerate immunosuppression or as an adjunctive treatment. There's only been one randomized controlled trial of IVIG versus placebo infusion, which was a tapering off schedule and favored the IVIG in improvement of disease activity score, but without statistical significance, conducted in Japan. So the conclusions from our Cochrane review of evidence-based medicine looked at the 12 randomized controlled trials, including more than 1,500 patients, and found that very potent topical steroids are the most effective and safe treatment for bullous pemphigoid, but their use in extensive disease could be limited by side effects and practical factors. Starting patients on prednisone greater than 0.75 milligram per kilogram per day doesn't seem to give any additional benefit, and therefore the 0.5 milligram milligram per kilogram per day lower doses may be adequate for disease control. The effectiveness of adding plasma exchange azathioprine to corticosteroids hasn't been properly established from studies. Combination treatment with doxycycline or tetracycline nicotinamide may be useful. That blister trial suggests starting with doxycycline is safer and non-inferior. Milder regimes of topical steroids may be effective as potent regimes for less extensive BP, but potent topical steroids are required for moderate to severe BP. And lastly, methotrexate may be a safer steroid-sparing treatment for bullous pemphigoid. So how do we assess the response to treatment? We'll obviously examine the patients, looking for blisters, eczematous lesions, scoring the patients where possible, looking for potential treatment-related side effects and comorbidities, looking for skin atrophy, purpura and skin infections, monitoring the blood pressure, respiratory disorders and infections, need to be vigilant for these, and regularly checking for blood counts, liver and kidney function, and blood sugars. So all of these drawbacks of existing treatment now lead us to the emerging targeted therapies for the management of bullous pemphigoid. And just for review, here you see our action players, BP230 inside the cell in the hemidesmosome and BP180 that binds to that and crosses into the lamina lucida, anchoring to other basement membrane proteins, the BP180. And when patients, for some reason, have some type of exposure of these proteins to the immune system and start to develop autoantibodies against them, this sets off a cascade of inflammation. And a lot of basic science research has gone into discovering which cells and which cytokines are playing a role in the inflammation that we see in bullous pemphigoid. For example, IgE seems to have a leading role in some of these patients. The levels are increased in untreated BP patients. An IgE specific to BP180 has been reported and can correlate with disease activity. And the pathogenicity of this IgE has been demonstrated in mice. There have been a number of case reports showing that anti-IgE omalizumab can neutralize the activity of this IgE and improve disease control in patients with bullous pemphigoid. As you see here in this series of 6 patients published, 83% or 5 out of 6 responded to omalizumab without any side effects. 50% had responded to monotherapy. And these patients had total IgE that was elevated, and most of them had increased eosinophils. What about dupilumab? There have been quite a number of case series now published of BP patients on this medication. Suggestions for it working are that many BP patients present with an atopic dermatitis-like phenotype, and that BP has been found to also have a type 2 immune response with increased IL-13, and multiple reports now of relapsing BP who couldn't get off prednisone and reduce their itch worked with dupilumab, and there have been lots of off-label cases from the United States and elsewhere. Dupilumab has been shown to improve itch and disease control in patients with recalcitrant bullous pemphigoid. In this 80-year-old man from Tufts University who had a history of latent TB and hepatitis B, his choices of treatment were restricted, and so dupilumab was used. And as you can see there, he achieved excellent disease control in only 3 months. Dupilumab has been shown to achieve disease control in as little as 4 weeks in a retrospective cohort of patients with BP. 146 BP patients in this cohort were treated with dupilumab, and 127 of them, or 87%, treated with 300 milligrams every 2 weeks after the initial standard dose of 600 milligrams, achieved disease control within 4 weeks. 35% of them, or 52 patients, achieved complete remission, and almost 9% only relapsed during the observation period. Because of this rapid and sustained improvement in BP dye scores, itch scores, and autoantibodies against the BP antigens, total IgE levels going down and eosinophil count were reducing, all of this suggested that it would be worth doing a clinical trial of dupilumab or BP. Here we see yet another publication here in JAMA Dermatology, whereby 73% of these patients did not report any adverse events. The most common AEs were just mild infections and eosinophilia, and serum autoantibody BP 180 levels greater than 50 were associated with 4-week disease control, and male patients were more likely to relapse. Patients with anti-BP 180 levels at least 50 and female sex may respond better to dupilumab. Hence, the Liberty BP phase 2-3 trial, which is currently being conducted worldwide, was designed to examine definitively whether dupilumab versus placebo added to the standard 0.5 milligram per kilogram per day prednisone could enable patients to taper off prednisone quicker, and it will be very interesting to see the results of this study. Other therapeutic targets in bullous pemphigoid are shown here. Of course, we have the therapeutic target of interleukin-4 receptor with dupilumab. The trial is nearly completed. Reslizumab, anti-IL-5, where there was a case report showing its therapeutic effects. Bertelimumab, which was a drug that targets eotaxin-1, increased in BP, had promising results from a phase 2 clinical trial, but so far hasn't progressed to a phase 3 trial despite these results. Omalizumab, IgE, a phase 3 clinical trial in progress. Efgartigimod, it's an FcRn inhibitor that reduces IgG, and currently being conducted, there's a phase 3 clinical trial. Other emerging therapies, as I mentioned, this SALAD study of efgartigimod for bullous pemphigoid is taking a similar randomization as the dupilumab trial. Patients are given 0.5 milligram per kilogram per day of prednisone and then randomized to either efgartigimod versus placebo. This is given as a subcutaneous injection weekly, and the patients then have to see if they can get completely off prednisone at a certain time point at week 36. So, in summary, the growing incidence of BP warrants expanded awareness, especially on the atypical non-blistering presentations. The temporary or long-term use of systemic immunosuppressive agents is remaining for now the mainstay of treatment for severe bullous pemphigoid, but its use can be very problematic in the elderly due to their comorbidities and other age-related changes. Targeted therapies are now on the horizon and are in development to address the underlying pathology of patients with bullous pemphigoid. So I'd like to thank you for listening today. That ends our discussion for today. I hope you found this activity informative and useful to your practice, and I encourage you to participate in the other modules which are part of this curriculum. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SVX860. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals.